Hey everyone, this is Victor from Cyborg for Life, and I want to welcome you to episode 177 of Limb Lengthening Live, where the patients interview the guests. And today we have some very special guests with us. That's right, we have world-class limb lengthening and deformity reconstruction surgeons with us. First up, right to the side of me, we have Dr. Frans Berkholz, hailing in from Stellenbosch, South Africa. Hey, Dr. B, how are you?
Hey, good on you.
All right, and we also have Dr. Michael Asiag from my hometown in Baltimore, Maryland. He's driving home from worked a long day, but he's still gonna, give it up for you guys there because he loves you patients. So, Dr. A, how's it going?
Thank you so much for having me, Victor. I appreciate it. Sorry, I'm in my car. I'll try to stop soon.
You are fine. You are fine. Take your time. Now, guys, just so you know, we may have more surgeons coming on later, but these are our first in the pipeline because they both have to go in about an hour or so. So they're going to lead it off with some of your discussions, your questions. So if you're in the chat, you're going to get second priority because there were submitted questions first. So the surgeons are going to take those first. But first off, before we do any of that, I just want to kind of give each of these surgeons some time to talk about their clinic, where they're located, any new updates that are happening, because it's been a while. We usually do this, like, I try to do it quarterly, but I was competing in my sport, so didn't get around to it this year, but they're back this time. So we're going to start with Dr. Berkholz, and then we're going to talk to Dr. Asiag for anything that's happening new at their practice, and then we'll get into the questions. So Dr. B, tell us what's been happening with you. Anything new?
Yeah, there's a lot of stuff happening. I think the biggest change has been the fact that we have not been able to secure a reliable source of Precice nails. So we are using Fitbones as our primary lengthening nail at the moment. And I must say that the results are encouraging. I think we've gone through the learning curve, and we are seeing incredible amounts of bone growth on these nails. Dare I say, sometimes more than what I used to see with the Precice nails. So I'm very excited about that. That patients are growing and they're lengthening reliably. So that's the one big change that has happened. I think maybe parallel to that or related to that is that we are launching, or we have spent a lot of time in working towards a better recovery facility, something that is scalable, something that is more medically orientated. And we've branded this as the Ascend Recovery Facility, and that facility will be a benchmark of what recovery facilities should be. And it will be the place where we will put our patients during their packages or during their recovery phases. The facility boasts on-site gym facilities, hydrotherapy, curated kitchen, professional kitchen. There's good security, good electricity, good internet, so all the stuff that you need in a facility like that. But apart from that, I think the biggest advantage is because we have a bit of economy of scale, we could actually reduce the cost, and I'm transferring those costs directly back to the patient. So I'm running a promotion at the moment where we've lowered our cost for our 4-month packages quite significantly. And also our extension packages beyond the initial sort of surgery package has also come in at a much more competitive price. So I'm very, very pleased that we've been able to do that. So I think it's firstly a better facility, but it's also a cheaper facility, if you want to put it that way.
That's awesome. Yeah, so you're working with the situation that you've been handed, unfortunately, with this nail situation. We really appreciate that as a patient. But yeah, it's really crazy. So just as you were speaking, I posted your link below so patients can find out that new information, that new promo that you're running on the link below. And also, I also posted Dr. Asiag's website, HeightRx, below, and he's going to let us know what's happening with his practice over at the Limb Lengthening Center there in Baltimore. So Dr. A, what's new with you?
So what's new at ICLL? So we're still the good old International Center for Limb Lengthening in Baltimore. We still have the amazing Hackerman Pat's house, which is our home away from home. Nice little community. I think it's our strength. Hi, Shahab. Nice seeing you.
Hey, how you guys doing?
Great. So what's new otherwise is we have created partnerships with meal delivery services called Jimmy's Famous Meals and Cook Unity, so that our patients can, local Jimmy's Famous, right? So our patients can have up to 21 meals a week for the objective of bulking which is great for bone growth. We've created partnership with Karen Sorensen, who's our home care extraordinaire. So she organizes transportation, she organizes home care cleaning services, anything that someone who's relatively handicapped needs. We've created partnership with a surgery center where now we do 90% of our limb lengthening, one leg at a time, to decrease the rate of fat embolism. We haven't published our data yet, but so far, out of 130 patients, we have had 0 fat embolism since we've been doing it one leg at a time. So we know it works. We just don't need the scale to show it and to publish it. Patients save a lot of costs. They save up to 30 to 40 grand by doing in that route. So it's also more affordable. And we are working on creating more partnerships with housing, because right now Hacker and Pat's house is extremely popular, and it's what people want. So we're working on opening more rooms, growing in height or towards the parking lot, and that should happen within the next couple of years.
That's incredible. And I can attest to that. I visited some patients there over the summer, saw some of your patients, and it was jam-packed. They all rolled out in their wheelchair. I was like, bring on the wheelchairs, let's go. And
it's a community. They go to the restaurants together. They go to the Silburn Arboretum together.
The gym.
They have outings. Yeah. And thanks to people like you as well, who gives them rides once in a while, right? For events or some other ex-patients. People have a blast.
They do. It's great there. Absolutely. So that's awesome. So you're really connecting and kind of making this like a very comprehensive service. I love that, because like you said before in previous podcasts, Dr. A, limb lengthening is not just surgery. It's not just PT. Those are huge aspects, but there's a whole lot more: nutrition, caretaking, all of those things. You got to live your life. So that's fantastic what you're putting together over there. Awesome. So moving right along here, we have Dr. Shahab Mahboubian from the West Coast there in LA, Los Angeles, California. Dr. M, how are you?
Good. How are you? Good to see you, Victor. Michael, good to see you. Dr. France.
Good job.
Very nice. Is there anybody else on?
There may be some more joining later. Some people are working a little bit later. Yeah, but we're going to be on for like 2 hours. But these two in particular have to leave in about an hour. But they're front loading.
You do too? Just so you're aware.
Okay, that's
Michael.
perfect.
Where are you driving, man? You got the seatbelt on. You're driving. Where are you going?
Oh, you got to be safe. Better be safe than sorry. I'm going home. I just finished my OR day. I'm going home to my family.
I love it.
Very good.
I love it. All right. So, Doctor, and what we're doing here, we're just introducing the surgeons, and then we're giving you a chance to kind of just share any new updates at your clinic, facility, and then we're going to get into some questions that were submitted. And there's some people in the chat as well. So yeah, what's been happening over at the height lengthening clinic there in LA?
Things have been good. It's been quite busy, actually. Actually did a couple of surgeries today, but people seem to be up and coming now, and still very interested in getting taller and undergoing the height lengthening surgery. We're waiting to hear more advancements from Globus, but so far, using the Precice two nail has been great. My patients seem to be doing well, but I do have some questions to ask the other surgeons about some of their techniques that they use, but we're also here to answer any questions that patients or people that are interested in undergoing the surgery. I'd be happy to answer those questions as well.
Sounds great. Yeah, and that's one thing that we definitely want to do here. In particular, Dr. B brought up at the beginning here. Unfortunately, there's a shortage of Precice 2 nails internationally, but he said that he has great success with the Fitbone nail. So we can definitely discuss that in a minute here. So what I'll do, I'll try to bring up some patient questions, and then we can have some surgeon discussion and go back as long as we can until you guys have to go in the next 40 minutes or so. All right, so let me go ahead and share my screen here. This was a patient question, and this first patient in particular had some questions about these different topics. And the first topic was about the X-ray versus an EOS, scan for the canal measurement of the intramedullary canal. So the first question about the calibration of the ball when you're doing the X-rays, he asks, when X-rays are taken with a physical 1-inch calibration ball placed near the legs, how accurate are the inner and outer canal measurements after calibration? I'll throw that to you, Dr. B.
Yeah, it's an interesting question. I think what we need to fundamentally understand when we're looking at X-rays is we're looking at shadows of a patient's anatomy. So we're looking at a projection, which is a flat projection of three-dimensional anatomy. And at best, the measurements are not 100% accurate. So as much as we would love to say that we can measure to accuracies of less than a millimeter and 0.1 or 0.2 millimeters, the truth of the matter is we cannot. And there are a variety of factors that come into play, which your poster has asked there or commented on. So machine settings technician, distance of the beam, all of that stuff plays a role. It is really important to have a well-calibrated X-ray because even the digital X-rays, the DICOM systems, do not give you an accurate number. You have to still recalibrate the image. Now, using a calibration ball is a good technique, provided that the ball is situated exactly at the same depth as the bone. So if they stick the ball on the front of the leg or the back of the leg or somewhere in between, then it's not going to give you an accurate calibration because it's not at the same distance from the machine as the bone. And so even these calibration techniques are not 100% accurate. So sorry to burst everybody's bubble, but there's actually no way to measure absolutely accurately without physically taking out a caliper and measuring on the bone. And we see this not only with the canal width and planning, we see this across orthopedics. It's not only for limb lengthening, it's in arthroplasty, it's in fracture care, it's everywhere. Templating is good and we can get pretty accurate, but there's always a little bit of variance. And, you know, so it comes in with the planning, but it also comes in with when we're doing distraction and we're evaluating how far the nail has moved, how far the patient has lengthened. It gets even more complicated because sometimes the positioning changes because of knee flexion contractures or hip flexion contractures developing. The beam is not at 90 degrees to the bone anymore because the femur is slightly tilted. So now you've got a foreshortened view. So all of these things come into play, and these are the things that you know, myself and my colleagues have spent many, many years trying to perfect. But even with that, you know, it's not 100% accurate.
That's incredible. And Dr. A, is it true that I've heard this before, that surgeons really can't tell how big the canal is going to be until they get intra-op, like actual to the surgery? Is that true?
Well, there's a margin of error. So Franz did a wonderful job at explaining where that margin of error comes from. So we can narrow down our canal size for the nail size. But I tell all patients, you know, it's really a game day decision. There's a 90% chance that your bone is going to tolerate the 10.7. But if my measurement is wrong, we have the 12.5 available, or whichever the anatomy of the brand that you're using has. So we have a good idea, but it's a game day call. And I'll go even further. Even if you have an EOS, so we have an EOS in our facility that there's an upcharge for. And the truth is, even with an EOS, if the technique is not perfect, if there's been a little bit of movement throughout the exam, the EOS gets movement artifacts, and it still becomes difficult to measure. It's more accurate. However, there's always going to be a margin of error, whether it's from the examination, the posture, the incidence of the beam. So nothing in medicine is 100%.
Got it. That's a fantastic explanation. So yeah, but just joining to the show, let me just do that now while she just came on. Another fan favorite surgeon. We have Dr. Marie Gadelovich handling in from Montreal, Canada. How are you, Dr. G? Oh, she's muted. I'm sorry. I muted her for a second. There she is. How are you? Oh, we still can't hear you. Huh. Can you guys hear her? You didn't hear her?
No.
Wait, I think I hear you now.
Can you hear me now?
Yeah, I can hear you now. Okay, we're good. We're good.
Okay.
Okay. All right. So Dr. G, what we were doing, as each surgeon comes on, because everybody's kind of on a different time schedule here, I just want to give you a chance to kind of like share any new updates that's happening at CLLC there in Montreal. And then basically we're going to go back to some patient questions and then we'll do surgeon discussions. Like I said, Dr. A, Dr. B have to go in about an hour, and Dr. M, I think, as well. So yeah, so go ahead and feel free. The mic is all yours.
All right. Well, the update I think that the patients are all sort of starting to talk about is that next year, as of January, I'm taking a 1-year sabbatical from the hospital, and I'm going to focus on the Canadian Limb Lengthening Center.
So you're going to be focusing on like just working with your like, oh, that's huge. That's big.
Well, focusing on all the deformities from across Canada and my aesthetic patients.
Very cool. I love that. That's awesome. Very cool. All right. So, and I know, Dr. G, you had some topics that we wanted to discuss. You sent me an email that we were going to discuss on this when I contacted you. So we'll do that in a little bit. But let's get back to that patient case because you had some burning questions here. So we're moving right along. This will be for you, Dr. M. He's basically asking about the non-calibrated. Oh, actually, Dr. A just kind of answered that. So we'll move right along. Now, he did say that if a patient brings 2 sets of ooh, sorry about that. Let me go back here. If a patient brings 2 sets of images, calibrated x-rays and EOS without calibration, and the calibrated x-rays show on the canal is 0.6 millimeters wider at the narrowest point and 2 millimeters wider externally, which imaging set do you trust more for implant sizing and why?
Can you explain to me what EOS is? Because I'm not familiar with the term.
EOS, Shahab, it's a slit type of x-ray that needs no calibration. So it's basically a beam that moves up through a little slit. It's a fraction of the radiation of a regular x-ray. And with certain softwares, it can provide 3D reconstruction. It can provide axial and rotational information. It's a pretty neat tool. It's very expensive.
It's used a lot in peds, Shab.
Yeah,
because it decreases radiation, all the scoliosis, yeah.
So got it. Yeah, that's not something I usually use. I like the technique of trying to get the pelvis and knees and ankles all in one film, so I could do the best calibration myself. Dr. Franz also mentioned that even with a calibration marker, you can have some variations. But it's always good to be prepared at the time of surgery. So, even my own measurements that I make in the office can be off. And sometimes they are, depending on the positioning of the patient, depending on where the calibration marker is. So I'm always prepared with different sizes at the time of surgery. And I always put in what fits best for the patient. So the calibration is good because it gives us a general idea of what to look for with diameter as well as the length of the nail that we're going to use. But in the end, it's what happens during surgery. But as long as you're prepared for it and you have several different sizes, then you should be good. And that's usually what I do, and put in the best fit nail for the patients.
Fantastic. All right. And yeah, I think that's kind of what he was saying. He's a lightweight adult male with narrow femoral canals where only the 8.5 millimeter nails fit. And he's asking Dr. Marie Gudelovich, what safe maximum lengthening amount in the femurs before the risk of bending or nail exchange becomes more significant?
Yeah. All right. So the first thing, I don't know if you guys touched on this, but patients really focus on the measurements, but the same surgeon can measure an x-ray twice and not get the same measurements. So the measurement error is like up to 4 millimeters. That's huge. And there's studies that back that data. So, I think that they have to focus a little less on some of these measurements and trust some of the experience that we have, because we're using our experience to guide how we're what size nail, what length nail, so on and so forth. To me, an 8.5 nail is not an adult nail. I would never put in an 8.5 nail in an adult. Even in my tiniest, smallest Asian patients, they don't get an 8.5 nail. It's just not a good idea. It doesn't have enough weight bearing capacity to even do transfers. So it really is not, especially completely lengthened. The safe amount is the amount that the patient lets you lengthen up to about 8 centimeters, or what the nail allows you to go to if we're using a precise nail. I think 8 centimeters has been shown to be one of those magic numbers in the femurs, and less than that in the tibias. But again, this is always, patients can't come in with it's not Walmart. There's no return policy. It's no guarantee. You're going to get what your body allows you to get safely. And for the femurs, I would say it's pretty reliable. You could probably get most patients to 8 centimeters, but not everybody.
Okay, very, very well. The next, yeah, so he was just asking a lot of questions about that. I think that kind of covers that topic there. And he did bring in with him x-rays that were measured from different clinics that he was just doing consultations with. And I think it kind of falls in line with what all of you surgeons were saying here at different parts. And you really don't know until you like kind of get there and actually measure it. That's what Dr. Burkholdt said. It's like with a tape measure. So yeah, so that's kind of like that topic there. Okay. So now before we go to patient 2, I want to give the floor to Dr. B. We want to talk about a little bit about the Fitbone nail compared to the Precice nail. That's one of the surgeon topics that I want to discuss. And we'll go back to the patient case and then back to a surgeon topic, and then we'll keep rotating. So Dr. B, yeah, the mic is all yours. So you said that you saw some great success with the Fitbone so far compared to your previous usage of the Precice 2. Can you explain some of the similarities and differences of the Fitbone versus the Precice 2.2 and the size differences and things like that?
Yeah, look, it's a big topic, but I'll try and condense it for you. It's like driving a car. You can either choose a Mercedes-Benz or a BMW. Both will get you to the end result in the same or in a similar way, but they will feel different, they will look different, they will drive slightly differently. And ultimately, it's about the surgeon behind the tool and not so much the tool itself. So I think Maria touched on that very, very nicely to say that we do rely a lot on our experience. And I do think if you put a good tool in the hands of any of these surgeons, they will be able to get a good result. So the quality of the osteotomy, planning, all of that stuff is probably much more important than the physical nail we use. Some myths around the Fitbone nail. It's not a new nail. It's been around for 20 years at least. It's pretty reliable. It works with an electric motor instead of the magnetic and gearbox. It's made from stainless steel versus titanium in the Precice. So there are differences. It can also retract. That's one of the other myths. You'd need a special control set, but you can actually retract it, so it doesn't have to only go in lengthening. It can also shorten. It's not labeled for shortening of fractures or non-unions, but it can retract. If we go too far, we can actually pull it back. I think the biggest disadvantage of the Fitbone, and that's been my biggest learning curve, is that in the current iteration, we only really have one length. We only have a 245 length, which was originally designed as a retrograde nail. But we do use them antegrade, and they work well antegrade. But you know, the fact is the nail is shorter, so you need to think much more carefully about where you place your osteotomy, and you know, some technical things that we as surgeons have to decide about. But ultimately, it's a pretty reliable nail. What I do love is the control set is nice and small. It's not like the old nuclear detonation device ERCs we used to get. So they're nice and small, and you deliver the energy directly to the receiver, which is buried underneath the skin. So you've got a direct connection between the energy delivery and the motor, which means that you don't have magnetic interference. If you have big quadriceps muscles or big strong blokes that need lengthening, you can actually get the energy to the nail properly. And yeah, lastly, reliability has been a question that I've been asked many times. I think reliability of distraction is something that ties into our previous discussion. Is some of it is just measurement, but some of it is that sometimes a nail doesn't distract as expected, and that happens across both platforms. That's not unique to one or the other. I've seen that happen in both, and that's a variety of factors that play a role. Some of it is operator error or deficiency in delivering the energy to the nail, whether that's a magnetic or a electric energy. But yeah, the last magic question is always weight bearing. You know, which of these nails is more weight bearing? You know, if you look at the FDA numbers, none of these nails are weight bearing. If you look at surgeon experience, I think all of us accept that these nails do tolerate some weight bearing. I do see in the Precice nails that they have a bit of flex due to the material that they're made of, which may or may not be a good thing, but it just stresses out our patients tremendously if they start seeing a bend on the nail. Because there is that sweet spot where bend is fine, but if you go beyond that, it becomes a permanent bend, and it can become problematic. So where that sweet spot is, we don't know. But yeah, so these are some of my thoughts about these two nails. I can go on for the whole night, but let me stop.
Do you see any bending with the Fitbone?
No, not bending of the nail. I think I've seen one. But what I do see is, that's the other thing with the Fitbone nail that's technically different, is it's got a single locking screw at the bottom, or locking peg. So you sometimes do see that sort of, what is it, male end that's distally, that slides on the locking peg, and you could have a little bit of deviation of the femur on that. So especially if your osteotomy is too close to the distal part of the nail, so you do see a little bit of the same effect. It's not the bend in the nail, but you do see a little bit of a varus effect on that. So with the Fitbone, it's really important, because you've got such a short nail, that you need to get your entry point absolutely right. And I do a digital templating for all of these using TraumaCAD or OrthoView or one of these softwares, because I think that's really critical to get your entry point absolutely right. And that varies by patient. It's not to say that it's always exactly in the same point. I would love a trochanteric version of the Fitbone, because I've seen with the Precice nails, I tend to favor more of a trochanteric slant in my entries. It's not a trochanteric entry, but it's somewhere between a piriformis and a trochanteric, but using a trochanteric nail, because that fits most people's femur shape better.
How much do you allow your patients to weight bear on the Fitbone?
I treat them the same as my Precice 2.2s during distraction, but then once we stop distraction, I'm a lot more aggressive, because the nail itself is stronger. So if you've got a decent regenerate, there's no crown that can fracture, there's nothing like that. So basically, once we get to the end of distraction, I progress them quite rapidly.
It's interesting, because the Precice 2 nail is at its weakest once it's fully lengthened out. And I've seen people that, unfortunately, when they fall, that's exactly where the nail breaks, is right at the coupling section.
Yes, that crown fracture at the bottom of the male-female junction, that washer basically that holds the rotation, and they fail that through rotation, and they at their weakest, like you say, when they're fully distracted. So that's actually when they get more active. That's when they're actually placing themselves at more risk, and that's why I think the Fitbone, in that sense, it doesn't have that risk. It's got a lot of other issues, but it doesn't have that issue.
That's interesting. Dr. B, would you say that there's a learning curve to using the Fitbone versus the Precice 2?
Absolutely. I think for both nails, I think all of us have gone through quite interesting learning curves in any form of complex surgery, and unfortunately, that's the reality of surgery. But that's why you need to choose an experienced surgeon who's already gone through a bit of a learning curve, that you're not the guinea pig in a way. Sorry, I'm always very honest and straight. I say things and then I regret it afterwards. But that's the truth of medicine. It is harsh, but it's true. Our experience is often gained on the backs of our patients, unfortunately, and hopefully, as surgeons, we have the grace and the insight and the empathy to see it that way. But yeah, I think there is a learning curve with both. There are subtle nuances, but any decent surgeon that does this for a living should be able to do a Fitbone quite nicely.
That's incredible. And Dr. A, I recently came across, I think in the last couple of months, a colleague of mine, he's a foot and ankle surgeon, and he sent me that Fitbone, Orthofix released a new bone transport Fitbone nail. I don't know if you came across this video on YouTube. Dr. B knows about it well, but this is a bone transport nail, but it also does lengthening. And some of the surgeons in the US have commented on this. If you have come across it, what are your thoughts on that nail?
I mean, bone transport nail is what we've been waiting for a long time. There was one on the market for a brief period of time that I used twice, which was great, but it was pulled off the market and we were waiting for it. Now, when we say that there is a version of the Fitbone transport nail that can lengthen, it means that it only lengthens a small amount. I believe it's only 3 centimeters, so a little bit over an inch. And the reason why we do that is that when someone needs a bone transport, it means that they lost a certain amount of bone, right? Whether it's in the street during the accident or from infection or from a tumor, from any cause. Well, sometimes in addition to that bone loss, the limb has been shortened a little bit through multiple surgeries or through a single surgery. So that hybrid nail allows to bridge the gap, but then also lengthen a little bit more if there's a leg length discrepancy. So as of now, obviously, it's not for the market of height lengthening at all. It's not going to be that bone transport nail. But, for some people who come back from certain clinics with bone defects and a leg length discrepancy because of nail exchanges, well, all of a sudden that can become a good option for them to bridge that bone defect, right? I've seen guys with a 5 centimeter defect and a 1.5 centimeter leg length discrepancy. They don't want 2 surgeries, right? They want a one and done. It's a long process, but a bone transport nail, the current iteration of the Fitbone bone transport, could allow to bridge these two, or to achieve these two objectives.
Interesting. Wow. Fantastic. Yeah, that's really great. And if you're just joining the show right now, we have world-class limb lengthening deformity reconstruction surgeons on the show. We have Dr. Franz Burkholz on here. All of their sites have been posted below while they've been talking. We have Dr. A from Baltimore, and his Height RX clinic is posted below. Height lengthening for Dr. Mabubian, and Dr. Gudailovich is also posted below. So if you guys want to book consultations with them, set up times to talk about that, any of your concerns, you can do that. Links are below in the description. So moving right along here, I know Dr. G had some a topic or two that she wanted to bring up, and then we'll go back to a patient case, because I know a few surgeons have to go in a few minutes here. So Dr. G, in your email, I have it here, and you had a few topics you wanted to touch on. One of them that your patient, these are from your patients essentially, but like one of them that I think that is really common, and I hear about it a lot, is what is the actual amount of weight bearing that I can do with the Precice nails? And Dr. Mabubian kind of touched on this just briefly here. My understanding is that some patients think that they can do full weight bearing, but that's incorrect. So can you talk about this?
Yeah, so I hear about what's happening with you, Victor, from my patients. They all come in, give me the updates, tell me who's talking about me, what they're saying, and all this other stuff. And then they were like, "You got to go on there and tell them that it's not a full weight bearing nail." And I'm like, okay. So I reached out. So because I had one patient bend a nail, and he was very upset. And I think he misunderstood, really. Like, it's not a full weight bearing nail. You can't drive, you can't walk on a treadmill. Like, there's certain things you just can't do with these nails until you're consolidated. And so I like to let them weight bear approximately 85 pounds. It's not as much as you think. If you were to so we make them do this exercise where they put their foot on the scale as they're walking, and they cannot pass that threshold. And so we try to keep them like more ginger than, like, you definitely don't want to pass that mark. So that's the max mark. So you should be putting a little bit less than that to be sure you're not overdoing it. But generally standing, I let them put their full weight supported with a walker or whatever. But if you weigh 160 pounds, you can stand. In my opinion, in my practice, in my experience, that's sort of what I see. Patients who will bend nails usually don't understand those intricacies. They're often not doing the walking properly. They're doing a lot of waddling, which is a huge bending moment on the nail, which is not a good thing. And they shouldn't be able to waddle if they're using their supports appropriately when they're walking. And oftentimes it's going to be because of poor bone growth. So, that I think is really the bigger problem. Then, because if you have enough bone, you're not going to have that problem.
Got it. Yeah. And Dr. M, you said it earlier, like you see that usually if a patient falls and they do bend the nail, it's usually at that juncture, the junction between the male-female part, when it's fully elongated, the nail is full distraction. What are your protocol for weight bearing with the Precice 2 nail? What do you tell your patients, like, let's say if their goal is 8 centimeters on the femur?
I think I'm a little bit more conservative. I tell my patients at the time of their consultation with me, so that they fully understand that this is not a full weight bearing nail. I also tell them, if and when the P-Max nail comes out, just like when we had the prior full weight bearing nail, initially they're in so much pain that they can't tolerate putting full weight on their legs. So regardless of the type of nail that they have to use a walker for the first few weeks at least. But with the Precice nail, they have to continue that until they are fairly consolidated. So I tell them no more than 75 pounds. That's usually my limit. I think some surgeons like Dr. G, they'll push it a little bit more, but I do have them work with their physical therapist to kind of get an idea of what 75 pounds feels like on one side. And if they're 150 pounds, then I tell them, well, you can stand. So for guys, like, they can stand and pee, for example, without the need for use of the walker, or they can stand and wash their hands or cook. There's a lot of things that you can do standing still. But as soon as you come and walk, you're basically putting your full weight on one side and then the other side. So that's when you need to start using the walker. So I make sure that they understand they have to use the walker throughout the lengthening process, and usually about a month to a month and a half after they're done lengthening, so that the bone can consolidate enough so it can support their weight. Some people well, most of my patients kind of listen to what I have to say because I drill it into their head from the very beginning, and I reiterate it at every visit.
That's fantastic. And Dr. A, I wanted to get your take on this. I just wanted to pull one question from the live chat, because I get this question about, I don't know, 20 times a day. It's, when is the PMAX going to come out? And although that may be an unknown, when it does come out, I know a lot of patients, the most common question right after that is, how much faster will I recover than the current P2.2 nail?
I actually just talked to one of my reps that works for Globus regarding the PMAX nail. And he said they still don't have a release date. They're still working on it. They still don't have a clearance of when they're going to release it. So, you know, I tell all the potential patients out there not to wait for the PMAX nail, because even if the PMAX nail comes out, I don't think you want to be the guinea pig and be the first ones to try it out. Because, you know, the first time it came out, there were some issues with the nail, and that's why they had to recall it. So the P2 nail has been out there. The Fitbone has been out there. There's a few other ones on the market that have proven that they're good. So I would not hold my breath for the PMAX nail. If this is the surgery that you need or you want to get, I'd say go for it. We have great nails that are out there, including the Precice 2 nail.
Got it. And Dr. Asiag, yeah, so like if you were to compare Precice 2 recovery times to the Precice Max or a full weight bearing nail, what would you say to a patient who's, you know, considering you for surgery?
Well, my answer is, you know, do you want convenience? If you want convenience, that's what weight bearing gives. It's convenient because it's more comfortable, because there's not as much use, and Marie is going to frown here. There's not as much use of a wheelchair. I'm a lot more conservative when it comes to weight bearing, because, you know, the FDA states that it's a 50-pound weight bearing nail across the board. And I used to allow 75 pounds for my 12.5 nails, and lo and behold, 90% of the nails that break are 12.5s. And I could show you the x-rays, just 12.5 galore. So that being said,
the crown,
rotational crown, but they can break in bending as well. They can break the housing in bending, in cantilever. So that being said, I tell everyone, do you want safety or do you want convenience? If you want convenience, sure, go walking, but you know, you have a 10% chance to break an implant, and of that, there's a 50% chance that you'll need an exchange nailing. So do you want to take that risk? Sure, use your walker more. Now, PMAX or any weight-bearing nail will give more convenience or more comfort during the lengthening because people are not sitting, but it's still lengthening. Joints still get tight, nerves still get irritated, bone still has to grow, and you're still relying on a piece of metal with mechanical properties to carry your body weight. So it's true, patients with stride were a lot more comfortable. They were walking earlier, and psychologically it has a big impact. So I think that's where it's going to make a difference. In terms of bone growth, in terms of rapidity or rapidity to bone healing, full bone healing, I don't think it makes that much of a difference overall. So ask yourself, do you want to wait a year to 2 years to do this? Do you need to do it now? What's your time crunch? Those are the answers to, those are the questions to answer right now.
All right. So it's more of a personal decision there. Okay. Very cool. All right. So I'm going to go back really quick to, so I think Dr. B and Dr. A will have to go soon. So we're going to take another patient question or two, and then we'll come back to the surgeon discussion here. And if any surgeon needs to go, feel free, but I will make sure your links are posted below right now. Everybody's is. Okay, there's Dr. A. Okay, so pulling back up the patient questions here. This question is about tibial axis deviation. So this question here for patient number 2 was, he has an x-ray, and I'll show it in just a second, but I'm going to read question 1. On the left tibia lateral x-ray, the upper tibia seems to tilt slightly forward while lower segments tilts backward. Could this indicate any tibial axis deviation or alignment concern? If present, could this affect knee mechanics such as hyperextension or overall range of motion? So I'm going to throw this to Dr. Burkholz, and I'm going to show the X-ray here. So this is his X-rays. I think, yeah, he has the right and left. So I'm going to just let you see the. Did he say the left? I think it was the left. Yes, left lateral tibia. So if you can see here, left lateral tibia. I know it's kind of analyzing an X-ray through a screen, but I don't know if you can kind of look through any of that. Is there some sort of axis deviation that he's looking at here, or does it look okay to you based on here? And again, this is just, there's no medical advice here. This is just a surgeon's opinion on what he's saying and what I'm asking him. And I'll let you read the question again. He's basically saying, could this deviation lead to any type of biomechanical issues later on?
I believe he's on mute.
Oh, Dr. B, I'm so sorry. I think, yeah, we can't hear you for some reason. Let me see. It might have a connection issue. Try to reconnect. I'll bring you back on. Sometimes it happens like this if you go off and come back on. It's finicky software sometimes. Live streams is not the best. But I'll go ahead and throw that to Dr. Marie. So Marie, do you want to answer that? And then we'll get Dr. B for another one.
Yeah, so I'm not entirely sure. I mean, generally the tibia will go into procurvatum if you don't, and valgus if you don't put the blocking screws. The surgeon here put a blocking screw. I don't see so much of a tilt that he's talking about. So,
well, here's my point, Marie. There's a medial blocking screw proximal. I think this is...
Yeah, I don't know why that was done.
There must have been a varus to valgus correction there.
Varus to valgus, yeah, maybe. But even, yeah, if you're going to do that, why put the valgus screw? Why put the screw in the lateral side?
If there's no contact with the cortex to prevent further valgus.
Yeah, maybe. Maybe there was a correction. But is he talking about the AP or the lateral? Because I think he's talking about the lateral.
Lateral, yeah.
Yeah, on the lateral, I don't see, Michael, I don't see that this guy's in procurvatum personally. Maybe like 1 degree. Like it's really not. There's the posterior blocking screws in the right place. I do see that on the left leg, that screw has a tendency to back out. That medial screw on the left leg, on a lot of tibias, they have a tendency to back out because the threads of the screw hit the nail too quickly and they don't purchase cortex. And so now I've started using a fully threaded screw there so they stop backing out. But that's always the left medial proximal screw. But otherwise, I mean, to me, the fibular osteotomy is a bit high and the screw's a little like horizontal at the syndesmosis distally. But otherwise, this looks pretty good to me.
Okay. All right. So we'll go to his second question here, and we'll throw this one back to Dr. B, and then we'll keep it moving along. So he's now saying on the left AP X-ray, the lower tibial segment appears shifted about 2.4 millimeters to the right. This adjustment was done to correct bow leg, just like you guys said.
Oh.
Yeah. So.
Yeah. So I don't know. Can you hear me now?
Yeah, we can hear you loud and clear. Yep.
Okay. Yeah, if you bring up that AP X-ray, it's actually a very simple reason. I don't see the pre-op X-ray, so but taking into consideration the history that it was in varus in bow leg alignment, the osteotomy was done relatively low down, or not relative, but it's done in the right place, but it's lower than where the apex of the deformity is, which means that if you correct through the apex of the deformity, you will have obligatory translation of the bone. And this is the stuff that we get excited about as limb deformity surgeons, which probably is not necessary for everybody to understand. But there's a reason why the bone translates there. And that little bit of translation there is acceptable in this condition because your overall alignment has been normalized. And really alignment is about aligning the joint above and the joint below. What the bone looks like in between is less important because alignment really restores the way that the joints move in three-dimensional space. And that's really what deformity correction is all about. So
that's deformity 101.
Yeah, exactly. And Michael works in a place where they've gotten this to a fine art, and they run the best deformity course in the world every year there. So yeah, so I think the point is, without measuring these X-rays in detail, I think this is a reasonably acceptable, or not reasonably, this is an acceptable X-ray. I would be happy if this were my patient. There are a few technical things that I might have done it slightly differently, but I don't think this patient should worry too much about the outcome here. What he should worry about is the regenerate, and that should heal properly. I don't know if he's finished lengthening. If he hasn't finished lengthening, he should focus on his PT and get his knee locked out, get his ankle up, use a slant board, do all of those things. Look at his diet, look at his physiotherapy, and for heaven's sake, not use corticosteroids to enhance his bone growth.
Well said. Well said. I love it. Yeah. All right. There we go. Yeah, he's really analytical here. The next question here, this one's for you, Dr. A, and then we'll go to Dr. M, the last one. Screw trajectory, asymmetry. So the tibial nail being used is not specific. And I guess we could kind of fast forward through this because, again, you all seem pretty happy. But he's talking about the AP screw on the left side. The proximal screw seems to pass closer to the fibula on the right side. Could this asymmetry lead to anatomical variation or surgical technique, or nerve irritation or screw loosening, anything like that, any type of complication down the line? I'll go back to it. I think he's looking at that screw, the proximal screw that Dr. G was talking about.
Yeah, I mean, we always see that most proximal medial left screw back out. It's just, it happens more than 50% of the time. It's a little bothersome, but it settles in a certain area where it creates a bump, and we would never really have to go and adjust it. No, I don't think the screw trajectory makes much of a difference. We can dial in the rotation of the nail so that we don't have to insert the lateral screw through in the middle of the compartment, so to decrease the risk of deep peroneal nerve injury. But it's just being careful with the drill and just inserting properly and slowly. That's it.
All right. Well said. All right. So we have one more question on this patient here, and then we'll go back to surgeon discussion. I know two surgeons have to go in like a few minutes. Dr. A and Dr. B, are you guys like 5 minutes out? Is that kind of like?
Yeah, 5 minutes.
5 minutes. All right.
Same here, Victor.
For another 10.
5 minutes for Dr. M as well. Okay. So what we're going to do, we're going to take this last question for Dr. M. I'll scan the chat for any surgeon-specific questions for those surgeons who are leaving, and then we'll come back to Dr. G. Are you okay on time for a little bit? Okay, she's okay. And then, yeah, we'll probably have some more surgeons. Dr. Conway might come and join us later. So, all right. So
she was still operating when I left. She was mid-case.
She was mid-case.
So,
okay.
Yeah.
He's giving us a timetable. I love it. All right. So this last question here is when to stop tibial lengthening. So currently he's at 2.1 centimeters. That's what Dr. B was asking. He does have some calf tightness. It's increasing, and dorsiflexion is down to about 5 degrees. At what point do you typically recommend pausing or stopping, for lengthening of the tibia? Is it, is reaching neutral of dorsiflexion a general stopping guideline, or like, what do you usually say, Dr. M, for your patients?
It's very individualized when to stop lengthening. It's very patient dependent. It's really what their goals are, what's the lengthening goal, how much they want to get. But there's also a functional issue as well. Yes. But I've had plenty of patients that have lengthened and they were well below 0 of dorsiflexion. So they actually have -5, -10, and they were still able to regain full range of motion with proper physical therapy, with home exercises to stretch out that calf tightness. Now, if they're unable to regain their full function and it's really interfering with their daily activities, well, there's always the option of doing a calf recession where you could actually lengthen the Achilles tendon. So that's like last resort, I would say. But I think most patients are able to regain their full motion if they stop within reasonable. But again, it's a matter of how much full range of motion they have once they've started lengthening. Before they've started lengthening, and where they're at in close proximity to what their lengthening goals are. So let's say this person gets to 5 centimeters of length, and now they're not only able to dorsiflex, or they've lost some dorsiflexion even below 0 degrees, and they can't even flex all the way down, because you can also lose plantar flexion, which is pointing your toes down because your joint gets tight. If I see that there's not very good range of motion beyond 30 degrees, I would say definitely stop. But again, are they doing the proper physical therapy? Are they doing their home exercises? These are all come into play. And again, it really depends on what their lengthening goals are. But most patients, once they've stopped lengthening, their tendons, their muscles tend to loosen up, and they're able to regain their range of motion because, you know, things start to relax and calm down.
That's awesome. Yeah. No,
I think it's very personalized of when to stop the lengthening.
Okay, so that's why they got to see the surgeon every 2 weeks. That makes sense. Now, Dr. A, like I had a question for you. Typically, a lot of tibial patients, they always ask me, like, do they really have to wear that night splint? It can get super uncomfortable. And I know that Dr. B was talking about wear your night splint, do your physio, this, that, and the other. And I was a tibial patient myself, so I know it can get uncomfortable to wear that at night. But what's your typical protocol for your patients who do tibias with the night splint, and how long do they need to wear it during the day? Yeah, what's the protocol for that?
So good question. It still comes down to, do you want convenience or do you want safety? If you want safety, wear the damn brace. It's going to give you a stretch over time for 8 hours during the night. And usually it takes about a week to a week and a half to break it, right? Initially, you wear it for an hour, it hurts the front of your foot. Then you might kick it off in the middle of the night. And eventually, over the course of a week, you get used to it. I don't use it for everyone. It's really a rule of thumb. My physical therapy department wants to incorporate it as a systematic option, and I'm amenable to that. So I think we're going to start doing that. But my protocol for those who wear the brace is wear the brace at night, stretch during the day, and that's really it. But the goal is 8 hours within 24 hours.
Okay, that's actually what I was prescribed. Pretty much the same thing, about 8 hours out of the day. Very cool. All right, so
ICL.
Yeah, ICLL. That's right. This one for you, Dr. B. So, do you only do Fitbone now? And then we're gonna wrap up.
The short answer is yes, and the reason is not my own choice. It's just what I have available at the moment. I do not have Precice available at all, not from my end, from the company's end, and I'm not sure why. Whatever the reason is, I'm stuck with Fitbone at the moment, but I do believe that despite that reality, that it is actually a decent nail and that I can make it work quite well. So on that note, there is actually a Fitbone trochanteric nail that has been launched that's in limited release at the moment, which I will have available from January onwards. More length options. It's got a trochanteric shape, and the initial testing data looks very promising. In fact, looks very similar to what a PMAX testing data looked like in terms of bending strength over 1 million cycles. That doesn't translate into what we can do with a patient. So I'm not saying, please don't misquote me, this is not a weight-bearing nail, but it is a nail that I think we will probably move more towards Marie's protocol of rehabilitation, ditching the wheelchairs, getting people earlier onto walkers and onto crutches. So I'm excited about that. And so obviously once that's official, I'll make people aware of that. But that's exciting. So the Fitbone nail platform is also evolving, and that's really good news.
That's
and it's going to be cheaper.
The problem, guys, with the weight bearing, it's not just, and we spoke about it, friends, when we're together, it's not just about breaking the nail, but it's also about breaking the mechanism. You know, even the engineers couldn't really tell us how much weight can that mechanism undergo axially before it just stops lengthening. And those are question marks that we have to answer.
No, for sure. And we will probably find that out the hard way, unfortunately, as was the case with Precice, where we actually pushed the limits and then found, okay, these are where the limits are, you know. So I think it's the reality of the beast. We'll have to be more conservative at the beginning, and then you know, do it in a judicious way. But I think it's really important to understand that limb lengthening is not a minor procedure; it's a major procedure. It's not only the procedure; it's also the process. You growing new tissue, you're growing new bone, you're lengthening muscles, you're lengthening muscle units, you're lengthening joints. You're going through a whole psychological metamorphosis, and the body goes through a really important healing process, which has all kinds of cytokines flowing around in the bloodstream and so on. So it's not a simple process. So it's not something where you have the surgery today and tomorrow you can walk, regardless of what the nail is we use. We see that with external fixator treatments also. The fact is that you can jump out of an airplane with an external fixator, it's strong enough. But, we do not see people going about their normal lives from day one after surgery. And so regardless of the device you use, we're not going to go about our normal lives, get back to work and just pretend that nothing happened. This is major surgery. It's a major process, and it needs the due diligence and the due respect of the process. It's not a minor thing. All the TikTok doctors and everybody else wants to make it a quick minor thing that you just go in. It's like a haircut. It's not that. It's really a big decision, and it's a difficult process, and it should be done with respect. Otherwise, we see the disasters that all of us have to treat regularly, and we really need to be cautious about that. Regardless of the nail we use, regardless of the so-called weight-bearing ability of the nail, it goes way beyond that. That's the smallest part of the equation.
Well said. Well said. All right. So yeah, I know that we have 3 surgeons who have to depart. So I'm going to let them have the mic one more time so they can say anything to their future prospective patients out there who are fans of them. So we're going to go with Dr. M first. So Dr. Mahboubian, the mic is yours. What do you want to say to your future patients?
Just want to say, make sure you are well prepared for your surgery, which is not just about, I always say, make sure you're nice and flexible and, work on your flexibility prior to surgery, because as you lengthen, everything gets tight. So the more flexible you are, the better you do. However, there is a psychological aspect of the surgery as well. You have to understand that life will slow down. You're not going to be able to get up and go out with your friends or get up and run around. Things slow down. You have to use a walker or a wheelchair for long distances. But the end result is amazing. All of my patients that have undergone the surgery, I mean, they're just a different person. They have so much more confidence. They're just happier about life, and they feel like they could conquer anything. So if that's your goals, then please look me up, and I'd be happy to help you out.
That's right. That's Dr. Shahab Mahboubian from the Height Lengthening Clinic in Los Angeles, California. His link is below. Dr. M, thanks so much for joining us.
I'm also on TikTok, by the way. Just
I was going to say, you're
so you know.
TikTok, doctor. I think I found
I'm a
him.
big fan of TikTok.
Like
right,
Dr.
guys,
B says.
So I didn't want to say anything, but I think he's the TikTok doctor.
Thanks, Dr. M. All right, Dr. A, you're up next. What do you want to say to your future patients?
Was that me? Sorry, it cut off.
Yeah. You, Dr. Asiak. Yeah.
Awesome. Well, listen, I'll repeat what everyone else says. Limb lengthening will always be limb lengthening, whether it's with Precice 2.2, Precice Max, Fitbone, Bone, whatever it is. It's a tough process. Our role, Marie's role, Shahab's role, Friend's role, is to ensure your safety. I don't think it matters if you go to either of us. You're going to get a good result or a good care, because we all have very high volume of this procedure. My best advice is safety first, convenience second, and cost third. So remember, you're dealing with your life, you're dealing with your function. Make sure that you're prepared. Make sure that your head is in the right place.
I love it.
And we look forward to helping you. We have a great team. If you decide to come to the ICLL, we'll unroll the red carpet for you.
They do it every time. Yeah, you can find his link below at heightrx.com or the International Center for Limb Lengthening in Baltimore, Maryland. Dr. A, thanks
you.
so much
Bye-bye.
for joining us. All right, have a good one. All right, and then finally we have Dr. Franz Bergholz. He just spoke well to his patients, but you can say any one last word or two if you want to go. I know your time is, you got to go soon. So
yeah, need to head off to a conference. No, I think I'm not going to do any marketing speak. I don't think that's appropriate for me to do. I think I would echo what Mike said, and choose your surgeon carefully. Have a consult with more than one of us. I would be more than happy if you had your surgery with any of the people you saw on the screen tonight. And but do your due diligence. It's a big investment in your future, and make sure you get multiple opinions and go with the 2/3. You know, if 4 of us do not all agree, go with what most of us say. And you know, and especially if you've one of these patients with a very tight canal or something that's not stock standard, get multiple opinions and then go with whom you feel the most comfortable with. Remember, it's an engagement that lasts a long time. It's almost like a marriage for a period of time. So you need to trust the person implicitly that's going to work on you. And we need to build a relationship. And, you know, like with any relationship, personalities don't always work well together. So you need to choose the surgeon you can trust and then walk that path. And then it's a little bit, I'm using a lot of analogies here tonight, but it's a little bit like pregnancy. Those of you who've had the blessing of having your first child, you would realize that everybody has an opinion. So ultimately, you need to choose 1 or 2 people you listen to and ignore the rest of the noise. And with limb lengthening, it's the same thing. Once you're on the journey with the surgeon, focus on that surgeon, trust that system, trust the people you've chosen, and go through that journey with them. Don't listen to all the noise, and especially don't go onto all the forums and things asking for medical advice. You don't want medical advice from a 19-year-old kid in his mum's basement. You want medical advice from somebody who's done the due diligence, who's spent the hours, who's done the 20 years of experience, who's done the 14 or 15 years at university. That's the person you need to go to advice to, not some random person on the internet.
On TikTok.
Anyway, that's my soapbox there for the night. Sorry about that. I had to get that out of my system.
It's so well said, and so it needed to be said. So I really appreciate that, Dr. Franz Berkholz from.
I wish I could stay longer. It was fantastic to see all of you, Marie. We still need to catch up in person sometime.
I'm coming.
Really good to see you.
I was invited to come in September. I'm going to see you there. Maybe we can organize. I can spend some time with you. That would be awesome.
Awesome. That will be great. I'll see you.
Dr. B, thanks so much.
Yes.
Take care.
Bye-bye.
All right. And then there was one. We have Dr. Marie Gedelovich. She's on here. She's left with all the questions, all the patient chat, but she's here. Yeah. But if you go, let me know.
I'll let you know. If you start hearing my kids screaming, you might have.
All right. All right. So she doesn't have to do her outro pitch yet. So what we're going to do, we're going to bring back on the patient question. Let me go down to the next one here. Okay. So we finished the tibia question. All right. So this is patient 3. And he basically has his x-rays here, and he's wondering about bone consolidation. So basically, he had his surgery done somewhere, but now he's back homeland, and he went to an orthopedic surgeon local to him, and she's basically kind of monitoring the aftermath. And unfortunately, his bones haven't fully consolidated. So I'll let you see the x-ray first, and then we'll read the question. So this is his right. So he had quadrilateral done, Precice 2 nail. That is, I know it's really blown up. Let me actually make it a little bit smaller. Hold on. Sorry about that. How do we do this? There we go. So we can get it down to normal size. All right. So that's his right leg. I should probably make that a little bit smaller. How can I do this? I'm sorry about that.
I see what I need to see.
You can see what you need. Yeah. Okay. And that's his left femur and tibia. And then here's a full length. Yeah, it's really long. So we'll look at the femurs, and I'll try to shrink it down while you're into the question. Okay, so that's that. And then let's read his question. So he's saying, my next appointment is in 3 weeks, 4 weeks after the last appointment for those x-rays. I don't think the consolidation will be much better since, you know, it hasn't been for over a year. It's been extremely slow. Should I be considering a more aggressive, you know, healing option like a bone graft? Do they think, meaning the surgeons, think I should be walking on it? Do they see something that I'm missing, or that the doctor that I'm with could be missing? What would be their recommendation going forward? It's been a year, and I have poor consolidation, and essentially the whole time.
Has it been a year from surgery?
Since he was done lengthening. So yeah.
Since done lengthening.
Mm-hmm.
Oh wow.
I know.
Yeah, so I'm not that worried about the right side, because the right side looks like it's really all continuous. Oh, there's a tibia.
Yeah, I'm gonna bring his tibia into the frame here. I just gotta resize it.
I'm not that worried about the right femur. He's still missing a lateral cortex. If you could just show me the AP of the femur again.
Okay. He's
right
AP.
Yeah, AP right femur. Yeah, so he's buffing up his medial cortex.
Mm-hmm.
So that right side can weight bear for sure. He can be walking on that. The left side, is slow. I'm not loving. He only has 2 cortices really, like the lateral barely, and on the posterior, on the AP and lateral there. So that one's a little bit more dicey, I would say. But to me, if he's not full weight bearing right now with crutches, that would be the next step to try to buff things up. Let me just see the tibias before I say that.
Sure. Let me, oh goodness. I don't know why I did that, but let me just pull it up here. Let me get it up one more notch.
It's the AP, and let's see the lateral.
So that's AP and then lateral. I think this lateral is a little bit. So it looks like the anterior cortex is really not.
Yeah, the anterior is not there, but he has the other 3 cortices. So for me, I think he needs to be weight bearing to help out the bone growth.
Okay.
At 1 year, you're starting to run into some trouble. Has he ever tried the accordion technique? I mean, that's something to consider on the left, because there's a bit of a gap there, even on the lateral. And so I'm worried that it's not going to progress. And I guess it can't be a year for everything. Either did he do it all at the same time, the quadrilateral?
He did. It was like, spaced out by a couple of weeks or a month.
Okay. All right. Yeah. I mean, that's asking the body to do a lot at the same time for sure. So I think you have to be more patient. I think it is better. I would advise walking with crutches or a walker, with putting full weight on the legs to try to help, consolidate things. I have had a patient that it took a really long time. It was an Asian patient, only on one side, and he just kept walking with the cane, and I wasn't seeing progress on x-rays. So that's the one thing for me, is if every x-ray is getting somewhat better, you're still making progress. If you're not making progress at like 1 month, 2 months, 3 months, nothing's moving, and that's a problem. Now, if he's not walking, the next step is to get him walking. After that, if the x-rays are the same, then you need to do something else, because that means it's just not going anywhere. So either an accordion, I've tried HBOT, so hyperbaric oxygen treatment. That worked on this one patient that it was like 14 months, still wasn't healed. Magic. It worked. Amazing. Yeah. So I was really, and he didn't want surgery. I offered him exchange nail. That was, my go-to. He didn't want the surgery. We tried the HBOT. It worked. Wow. So that's, if you have access to that, it can be a little pricey. I think it's a couple $1,000s in Canada anyways. But yeah, and it's time consuming. You have to go into this thing. They depressurize, they repressurize. It takes about 2 hours every, I don't know exactly how often, but it's time consuming. So I think those are your options other than a nail exchange, which, if you really want to get on with life, that's an option. I wouldn't do it everywhere. I'd probably just do the left femur, maybe both femurs. And then I think the tibias are well on their way. It's happening. So I wouldn't be too worried about the tibias.
I think that's exactly what he was advised as well. I think they said that his tibias are weight bearing. He can go ahead and do it, but he's waiting for his femurs because it's his entire leg. Yeah. So
yeah, for sure. Okay. And it also depends on how much he weighs, but I would say the walking is the next thing. And if there's no progress on the x-rays, then you need to do something else.
Got it. Yeah. So
I don't think a bone graft is required, though. I think an exchange nail would be enough. I don't think he needs a bone graft.
Oh, okay. Well, that's good news. Maybe he'll be happy with that. And like you said, you kind of start with the most conservative and then go.
Yeah, for sure. We always try to do what we can, like an accordion technique, something that I've never had to bone graft anybody yet. I'm not going to do it, but I have had to do a few exchange nails.
Okay. Very cool. All righty. Moving right along here. Let's see. Patient number 4. Oh, I didn't bring up his images yet, but I'll do that later. But let's just go ahead and answer these submitted questions. We'll go to the chat and then I'll bring up the images. So this one's about adhesion or friction after tibial LON. So in tibial, I know that you don't perform this, but like tibial lengthening over nail cases, can adhesions or friction type sacs form where the muscles or tendons glide over, like protruding locking screws or areas of external callus during healing?
I mean, they can. They don't usually. Usually, it's not such a big thing, but they can. For sure, they can, because you're moving, something over something else, so it's possible. But generally, you're going to lock the nail after you're done lengthening, so they won't really move over a protruding screw proximally, because the lengthening is going distal. So not usually.
Gotcha. All right. And then his second question here is saying, when an intramedullary nail is being used, why isn't intramedullary osteotomy more commonly used as a standard, less invasive method for creating the bone cut?
Not sure what you mean by intramedullary.
Yeah, I might have misinterpreted his question. I think I copied it pretty verbatim, but I did read.
When we're using an intramedullary nail, we use an osteotomy that's percutaneous osteotomy.
Yeah, let me go into Discord. What did he
drill
say?
and osteotome is usually how we do it. We wouldn't use something from the inside. It's quite complex to cut the bone from the inside. There is like a cutter that you can use. Maybe he's asking that, but that's not really necessary.
That's not. Oh, that might be what he's asking then. In
yeah.
Case. Got it. Okay. All right.
Yeah,
So,
some people talk about the periosteum versus, the blood supply from the intramedullary canal. They worry about that. Really,
mhm,
the most important part is not burning the bone thermally. No thermal necrosis, either when you're breaking the bone with the drill and osteotome or when you're reaming.
got it. Got it. Got it. Yeah. That's interesting. Yeah. That's intermedullary. Yeah. I'm reading the same. It's pretty much the same thing. So I think you interpreted it correctly.
Yeah, so there is a cutter. We don't use it ever almost, but there is
No.
something that you can put inside the bone to cut, but that's actually probably going to burn the bone. It's like a saw. We don't use it.
You don't need it. Okay, got it. All right. All right. So in the meanwhile, I'm going to bring up some questions on the screen here, and then I'll bring up that last patient's x-ray. He just wants to kind of get a prediction for your opinion on his consolidation. But this one here from Unsa is saying, I had femur limb lengthening. Outer bone width, it was about 22 millimeters, but the canal was 8 millimeters. Surgeon inserted a 12.5 millimeter P2 nail by over-reaming. I have only 3 millimeters of cortex left. It's now consolidated fully. Is it safe to remove the nails?
I'd like to see the x-rays to make sure that it's all even, but in theory, yes.
Okay. Very
Yeah,
cool.
in theory, I mean, I probably wouldn't have chosen a 12.5, but maybe the canal was bigger than it looked on x-ray and the surgeon. So what we do in the OR, I don't know how many times you've talked about this on your show, but we have a reamer that goes in to eat the inside of the bone, inside the canal. And once we hear something called chatter, that's when we know we're hitting the cortex. So it goes like, tick, 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 you hear the chatter.
Yeah.
So once, like, let's say I'm starting to get chatter at 10, well, I'm not going to put a 12.5 because then I have to ream up to 14. So once I start to hear chatter, I'm happy. If I have chatter at 12, then I'm going to go up to 14 and put a 12.5 nail. But if I have chatter at 10, you're getting a 10.7 because I have to ream to 12.5 to get the nail in. And so I want to put in the nail that fits best without taking out too much bone. So in this case, it's hard to know. I'm not sure why they put in such a big nail. Sometimes you have to consider the patient's weight and also how big their thigh is because you need to be able to communicate with the ERC. But yeah, other than that, once I hear chatter, then I'll take the closest size to that.
Got it. And that's kind of going back to that nail sizing thing that we discussed earlier. Got it.
And sometimes it's an intra-op decision, really. Like even though you think the calibration is not always right, every time you measure, you can measure wrong by 4 millimeters. So
interesting. So John 228 is asking, what happens if you have the Precice nail in you and you get into an accident and it gets crushed? Will the magnetic seal break and leak magnet into the body?
Yeah, I don't think that's how that works. It would be like you break a magnet in half. So generally, that's not where the nail will break. So that's one of the design flaws with the nail. Flaw is, in a tibia, if you look at a tibial x-ray, when you're lengthening, you're actually lengthening in an area where the magnet is. And so actually the nail doesn't hollow. And so I've never seen a tibial nail bend. So because if you're doing the osteotomy at the right place, your nail doesn't hollow there. And so you're not at the weakest part of the nail when you're fully lengthened. In the femur, you're always in the hollow part of the nail when you're done with the lengthening, exactly where the gap is. And that's where the weakest part of the nail is. And that's the weakness of having a big gap and having the hollowed part of the nail there. So if you're going to break in an accident, you're going to break there. You're not going to break the magnet. It's too stiff.
Got it. All right. So I did find
path of least resistance.
The path of least resistance. It's kind of like the structural flaw, but it actually works in its favor.
Yeah, the magnet's not going to be where it breaks.
So this is the patient's. I'm going to share my screen because he did send in his X-rays for just kind of like a thought. And this is his AP, and then he has his lateral views for right and left, and then basically he's just asking like how far out he's progressing. He's healing. I think he's done about 6 weeks in from stopping lengthening. He's just curious, like, what do you think? How long will he be on crutches?
Yeah, so show me and the other one.
Another one here.
Yeah, so he's got 3 cortices on both sides. For me, he should be full weight bearing on crutches.
A full weight bearing on crutches. Yeah, I think that's where he is
crutches,
now.
Full weight bearing, and then the following month, if the X-rays look better, the next step is lose the crutches.
Oh, cool.
So sometimes patients will use a cane. The reason for using the cane is not that they can't be full weight bearing, it's to decrease the waddling because they tend to waddle a lot. So if you use a cane, you waddle less, and then you can drop the cane after that. But some patients really don't want to use any more walking aids once they're done, and that's okay too. So he's pretty far along, I would say.
That's good news for him.
Yeah.
Very, very cool. All right. All right, so going back to the next questions here. Yeah, you got some huge fans in here. You got your Master Distractor, which has made a YouTube channel. He's been a huge help to the community. So he's one of your major superstar patients. Yeah. All right, let's see here. Let's see, questions. Okay, so this question from John again. He says, I have a disc hernia from my powerlifting, but my pain is settled and I have recovered. Am I contraindicated for Precice because of I might still need an MRI at any time?
Well, you can't get an MRI with the Precice nail in you. So you can get other things that might be able to help. Like there's sometimes you can do a CT scan. I think you're going to not be powerlifting when you're doing your lengthening. So it's going to help for not herniating another disc. But if you have a history of disc herniation, you're going to be a little bit more at risk for having like nerve pain during lengthening, having that, you know, tweak of that sciatica or like whatever it is that, you know, people talk about. But for sure, if you've had a history of disc herniation with any kind of like electric shocks in your leg, you're a little bit more at risk for having some of that nerve pain when you're doing the lengthening.
Interesting. Okay. So we're going to answer one more question here, and then Dr. G has a few more points that she brought up that she wants to touch on, and then we'll go back to answer the last bit of questions here, and then I'll hold it off until Dr. Conway comes on. She's still in the OR. So, all righty. So let's see. This question here from sequential quadrilateral limb lengthening. Can it be safe without a peroneal nerve decompression? I guess that's what they're asking here.
Yeah, so I don't know if I'm the right person to answer this question. I don't do this. I don't know what they mean by sequential. I do femurs. And then when you're done your femurs, like around 6 months, I'll do tibias. So at that point, most patients are back to their normal level of flexibility. And so I don't ever do a peroneal nerve release. I've yet to do a peroneal nerve release for any lengthening.
Wow. And for your tibia patients as well?
Nope.
Wow. And they've done so well, because I know a lot of them. That's
But incredible. I do an anterior fasciotomy.
Okay, I've had that done as well. Dr. Conway done that.
I do the anterior fasciotomy, and we lengthen slow with the tibias. So I've not had to do that.
Very cool. All right, so now we're going to go back to the document here. I just posted Dr. G's topics. I'm going to blow this up a little bit so everybody can read it. So these are some of the topics that she proposed to bring on and talk about, and I think they're fantastic. They're from her patients. So the number one question that she gets is, if I do my femurs first, how soon after can I do my tibias? Dr. G?
Yeah. So my general rule is about 6 months after femurs. I like the bone to be, 80% consolidated, but it doesn't have to be. I currently have a patient where that's the case, where the bone was not growing quite as much as we'd liked. And they were very concerned about doing their tibias, wondering if the body can handle making bone in the tibias while they're still trying to make bone in the femurs, which is a very valid concern. The thing is about the body is that when you create an osteotomy in the tibia, you're increasing the vascularity to the limb. By increasing the vascularity to the limb, you're actually helping the femurs. So for me, that's not an issue. The main issue is your flexibility. If you want to get the most out of your femurs and the most out of your tibias, if we're at 6 months and you still are not back to your baseline for your hamstrings and baseline for your basically your hamstrings for the tibias, then you're going to have a really tough time with your tibial lengthening. So we need to be able to get that full knee extension. Hamstrings need to be loose. We have to have good dorsiflexion. Like all of those things need to be in place. But for me, it's usually 6 months after the femurs we do the tibias.
Okay. Wow. Okay. And that's a minimum, right?
Yeah. I usually don't go anywhere before that, because I think you need the time to get that flexibility back. We need the time for the bone to consolidate. You need to it's 3 months of lengthening, then your 3 months of consolidation. You need to get a little bit of a break before you go in again. But generally by 1 year, you're done your process. Most people are back to doing, their stuff. So that's kind of the nice part about it. The other way we do things sometimes is patients will do their femurs, and then when they're doing their femoral nail removal, they're like, well, while you're at it, you think we can do the tibias. And that's something we do a lot of, because patients are so happy with their femoral lengthening. And if they've had a really easy time, they're like, why wouldn't I do my tibias? And to be fair to the tibias, they're a little more painful in the beginning. They're not quite as not as nice in terms of the first couple of days after surgery, but after, I think they're actually easier than the femurs in terms of, so basically we'll do, and I know some people don't like to do this because it is more surgery, but we do the femoral nail removal and the tibial nail insertion same time, same surgery. We save you a surgery that way. Wow. So I think people like to do that. Yeah.
That's huge. Yeah. So you can do it at the same time as removal.
And it saves you some money. So it's all good stuff. Yeah.
And you're out all at once, you don't have to go back.
Yeah, and it's the recovery is the same. It's not really the femoral nail removals that's gonna, they still stay one night, they're out the next day. It doesn't really change much for the recovery.
That's interesting. So let's just say that, assuming that you get a ton of like femur patients. Like how many, like what percentage of your femur patients would come back for tibia nailing? Oh, really?
Yeah. I mean, they all, like some of them don't even talk to me about their tibias, and then they've done their femurs. They're like, you know what? I want to just, and I'm like, okay, we're not going to be greedy. If you're just doing this for like shits and giggles, we're going for 2 inches, 5 centimeters. We're not going to like do anything. That is really the safe amount in the tibia without starting to get into complications. So yeah, and they're just happy to do that. They're like, okay, great. And because I guess, first of all, they have to have the funds available. But once we're going in to take out the femoral nails, like I said, if they've had a really easy course, they really just like, I might as well get this done. They see the difference. They appreciate the height.
Yeah.
So
that's
a lot. I would say before I used to say like 20%. Now I think we're at 50%.
Wow, that's huge. Yeah, I think I'm still at like 25, 30%, you know, at other clinics, but like.
Yeah, no, I'm telling you, like in the last year, a lot of patients have come back for their tibias. We've done so many tibias this year. It's crazy.
And do you still use the Botox for the calf and
calf and hamstrings?
Calf and hamstrings to help with the tibia lengthening. Incredible.
Yeah.
Okay.
And I don't believe in doing a gastric soleus release personally.
Yeah.
I know Shahab was talking about that. I think you lose a lot of strength. I'm not happy to lengthen patients' path. For me, the lengthening rule for the tibias is your knees are straight, your heels are down. Otherwise, we're stopping.
Right. Because there's no.
And I tell the patients, you think the tibias are going for 5, you're going to finish in like 2 months and a half. That's not happening. It's going to take almost like 3.5 months to get there because
we go slower.
Yeah.
That makes sense. So you can get that bone healing.
Yeah.
Okay. Very cool. So you just answered number 2. You can get them done at the same time, but and we talked about number 3 earlier. So
and vice versa. Like I said, sometimes we take out the tibias and somebody wants to do their femurs. So
vice versa too.
Yeah. Some patients want to do tibias first, whatever the reason. I had one patient, you know, he's really like quite short and couldn't touch the ground from a seat, from a chair, and was like, I just want to do this first because we did the tibias first. Then he's like, okay, great. Now let's do our femurs. Okay.
Ah, interesting. So it happens both ways. That's really cool.
Yeah, it happens more often the other way, but occasionally it happens this way. Yeah.
Yeah, people want as much height as possible usually.
Yeah.
All right. So yes, we answered number 2 and 3 here because we talked about weight bearing earlier. But let's talk about number 4 because this is like which patients get complications and why do they get complications? Is it because they don't listen to their surgeons or they just want to try things out themselves? Like, what do you say?
I don't like blaming patients. So complications can happen to anybody. Okay, it's par for the course. Like the problem with complications is patients think that it's never going to happen to them. And that's, I think, like you talk to them about the complications, you explain them the risks, but patients live in this like bubble where, and I would live that way too if I was getting this done, be like, that's not happening to me. I'm fine. It's going to be fine. That's not my issue. Right. So I think you have to sort of always understand that it can happen to you. And what I say to patients is if it happens to you, it's not a 1%. It's 100% you. It's not a 5% risk. Like it's not 95% okay. It's 100% your complication, which you're suffering from. Luckily, it doesn't happen that often. And oftentimes I have to twist their arm when I'm seeing something coming, like patient with a bent nail. I had to twist this guy's arm to get the nail exchange done. I'm like, this nail is going to break. Like I cannot live. I am like having heart palpitations. I need you to understand that this is going to be an emergency and I don't want it to get there. We need to do an exchange nail. Like, so sometimes I have to twist their arm, which is, I find ridiculous because like, you know, but I think mainly the complications, either I did a bad job explaining something and they misunderstood how much weight bearing they need to do. But more often than not, it's really like they won't come to their physio appointments. All of a sudden, my physio's like they've canceled 2 or 3 physio appointments. Then I don't have anybody seeing where they're at. So how am I supposed to know what's going on? My physios communicate with me. Every time I have a patient come for follow-up, I have an update from my physio to be like where they're at, what we're doing. And if there's something during the 2 weeks, my physios alert me right away. So if I don't have eyes on you, I can't really, you know, I can't predict what's going to happen. So that I'd say that's the number one is if they start canceling their appointments, if they don't show up, if they're not doing their exercises, and if they, again, like it's a relationship, like Dr. Burkholdt said. So I don't like blaming anybody, and I have always a part. Like I always feel like I have a part in the blame because if you didn't do things the way I explained them, I didn't maybe do the best job as I think I did to explain them. So. Yeah. So, but I think that's where the complications come in. And again, it's not always anybody's fault. You know, the nail has a weakness in rotation. The patients, we tell them all kinds of ways to stay safe in terms of turning in bed and all this other stuff. But at the end of the day, that is a weakness of the nail. That is a flaw. And so it's going to happen. Right. So, yeah. So that's kind of one of those things.
Absolutely. And I think you're being a little modest because it's like you're talking from your patients. It's like, hey, look, if you miss physio or whatever, like that's how complications can develop. But let's talk about other clinics internationally and abroad. Like maybe not all the blame is on the patient, right? Because maybe the surgeons are a little less experienced than,
Yeah,
or they use an obsolete technique. Can you talk about some complications that you see that you treat?
Yeah. So I do see patients with complications that come from other places. A lot of non-unions, deformities, basically some empty gaps where there's no bone. I have a really unfortunate patient who has a foot drop because of a repeat surgery during lengthening, because of a complication in that place, where because once you've had a lengthening done, when we bring you to the operating room and we put your legs up, like straight up, and your nerve, everything's tight, well, now you just stretched her nerve. So that's really an unfortunate complication that's really hard to recover from. So some stuff we can fix. I've had patients come back, walking on their tippy toes, unable to get their heels down, doing the gastrocsoleus recession, doing IT band releases after the fact. It's sometimes doing nerve releases because they're entrapped because they did too much length, having to fix ankles with syndesmotic screws and lengthening fibulas. And so there can be a lot of issues. And it's a lot more work to fix the disasters, but also patients have these high expectations that they're coming to you and I'm trying to fix somebody else's mistakes, right? And sometimes it takes more than one go. Like I can't guarantee you that I'm going to get this on the first go. I'm going to try, but there's a lot to fix often, and got to take out broken hardware, fix deformities, and then try to get the bone to heal. So there's a lot going on. I'm not going to do more than 4 or 5 hours of surgery. That's just too much. So sometimes we got to do another surgery. So we got to have objectives. So usually the objective, you got to forget now about your length, and you got to remember now we're trying to get you pain-free and functional. That's the two goals of whatever is happening. And then after that, let's talk about the aesthetics, whatever's going on with your legs in terms of length, whatever's going on in terms of deformity. We'll try to fix those at the same time. We'll try not to affect your length. But my two goals, if you're coming to see me with messed up surgeries, is function and pain.
Wow. That's so powerful, because I get a lot of consultations. I talk to patients all the time, and they find a surgeon that may be more affordable to them internationally, and they come across and they try to say, is this a good surgeon? I tell them, look, how many they say they do external fixators or deformity correction. I'm like, well, okay, but how many patients do you see of theirs who have had successful outcomes? So and they don't really have an answer for that.
Right.
And I'm like,
and the other thing is that aesthetic lengthening is not the same as having a limb lengthening.
Absolutely right.
It's really not. It's a whole different ball game. You need to have experience with aesthetics. I understand everybody has to start somewhere, but your surgeon needs to be honest. If they've done one case, then that's what you're going to get. You're going to get the experience of one case being done. And so even if they're a great surgeon and they're doing all kinds of limb length reconstruction cases, if they don't have experience, if they don't have a team, if they don't have the complications and know how to deal with them, that's really...
That was my exact answer, because I was like, okay, it goes both ways. It's like, don't get me wrong, you want to understand deformity and discrepancies and stuff to be able to do cosmetic, but it's like you also have to have cosmetic to understand cosmetic, right? Like you have to understand it's a process.
It's a different ball game.
You're going for more length, and not only that, there's more physio, there's caretaking, it's a process. It's not just
the physio. I mean, again, like Dr. Burkholz was saying, I think it is like a marriage. And you got to like your surgeon. Like, I get that I'm not everybody's cup of tea. I totally understand that. And I have refused patients. And I've literally said, this is not going to work because either disrespect or, there has to be a minimum amount of trust and respect. And if we don't have that, it's not a good fit. It's just going to be a miserable ride for me and for the patient. So I have refused patient based on that. But generally speaking, I'm very open and honest with my patients. I treat them like I treat family. They have my cell phone number. So you have to like me. You have to like your surgeon, not me necessarily. But if you're going to come to us, you need to like me. Because if you don't like me, it's not going to be fun for me, and it's not going to be fun for you.
Right.
So and again, I'm not everybody's cup of tea. Dr. Burkholz, I think he's amazing. If I had to pick, I'd pick him or Dr. Asayag, or I love those guys. I love their personality. I love who they are. I love how they see things. I know that if I had a complication, those are the guys that I would trust to take care of me.
Absolutely.
So that's where it really comes down to. You have to also have that fit.
Yeah.
And so that's sort of and I named only two of them. There's probably a gazillion other surgeons.
Right.
That do my surgery, but I'm just So, I don't know Shahab actually that well. So, but that's what it comes down to. You have to have a good experience. You have to Dr. Burkholz is really well set up with his he's like a one-stop shop. They have the accommodation. We don't have that kind of a setup here, which maybe this year we're going to work on as part of, the focus, but you have to be able to, find your accommodations. We give you a list. We recommend places that can deliver food and like healthy food options, but we don't have it, the same kind of setup. And I think Michael has like the Hackerman Pratt house or whatever it's called there. So you have to also be comfortable with the logistics setup of it all. And so we have Layla, who's really good now. She started in August. She's really getting good at helping patients sort out all the details and help with the logistics. But that's still something that's, something that's a little different in Canada. So yeah.
It's a work in progress, but you know what? That's what it is. It's
but the team is there. My physio team is amazing.
Absolutely.
That part, and that's the thing. We have a great X-ray place. We have we send patients for Dopplers to screen them for making sure they don't have clots. So we have a nice setup for all the medical stuff. It's the non-medical that we're still sort of trying to help patients logistically.
Right. I think it's such a comprehensive process that you have to look at the whole package. It's not just like you said, surgeon is super important. Don't get me wrong, and your physio is too. But it's like, hey, look, how can you get from point A to point B safely? That's what it's all about. So
yeah. 100%.
All right. Very cool. Awesome. So we're gonna take a few more questions in here, and then I know we'll just keep going for we're gonna cut it off at 7:30 anyway, but we'll see here. Let's see. So this next question from Luis saying, how much does a keen suffer in femoral lengthening? Does someone with a moderate cartilage damage or ligament injury are they a candidate for surgery? Thinking about conservative lengthening, like something like 5 centimeters.
Yeah. So how much does the knee suffer in femoral lengthening?
Oh, the knee. Okay.
Yeah. So I had a patient. He came to see me. He had really bad medial OA of his knee on one side. Absolutely wanted lengthening. Knows that he's going to need a knee replacement in the future. So we told him, all right, we're going to start with your tibias. This is an example where we start with tibias. We're going to fix the bowed legs. We're going to offload the medial compartment by fixing your bowed legs, and we'll lengthen at the same time. For that patient, I actually had to use a nail to offload, an X-fix, circular X-fix on one side to be able to get the correction where I wanted it to offload. Couldn't do it with a nail. Did all the planning, wasn't going to work. So the one side he had a nail, the other side he had an X-fix, got the 5 centimeters, got the alignment correction that we wanted. Still has terrible medial OA, but has no pain. Now he has no pain because we've offloaded him even with the lengthening. And now he just came back and we did his femurs. And so eventually he's going to need something, either a unicompartmental knee replacement or a full knee replacement. This guy's 60. So we're doing his femurs. He's doing great. And so, yes, there might be, but if you already have arthritis, your future is looking that way anyways. I don't think that it has a massive impact. Now, if you have patellofemoral arthritis, that might be the only caveat. When you do a femoral lengthening, you tighten up the quads quite a bit. You're going to feel that pressure from the patella squeezing on the femur. So until you get your quad flexibility back, you might feel it. You really might feel it. Or anybody who has patellofemoral chondromalacia, I had a patient like that, a female patient like that. She suffered a little bit during the lengthening, but once her flexibility came back and her strength came back, it was gone.
No problem. Wow. 60 years old though for that other patient. Wow.
We did his tibias when he was 55 or something. And he was so happy because he had no more pain. He's like, let me, and then COVID hit and whatever. And then he came back and we did his femurs. Yeah.
Wow. Awesome. I love it. Okay. So here we go from Jay. He's saying, do we know the long-term risks, maybe with something like muscle or nerve adaptation or anything with else with lengthening cosmetically? If this was from earlier. Yeah. Any surgeon has seen any data or experiences on this?
I think nobody really knows. I think the one thing we do know is in kids, if you lengthen them too much, you affect their growth plates. Same thing in the dwarf population. So we especially when they're kids, we want to be careful about not inhibiting growth. We know that it increases joint reactive forces during lengthening so that the pressure in the joint goes up. But as far as we know or think, that pressure comes back down once the muscles and the ligaments and everything, every stretch, you stretch once you're back to your baseline flexibility, in theory, your joint reactive forces are back to the same. Now, what damage does that do during? So cartilage getting squeezed is not happy cartilage. When it's feeling joint reactive forces, it's not happy. How much damage does that have long-term during lengthening? Nobody knows.
Nobody knows. Not enough data yet.
Because let's say you get your lengthening done, I don't know, you're 25 and you need a hip replacement when you're 50. How do we know it was because of the lengthening?
Yeah.
How do we know it wasn't because you played hockey for who knows, right? So you have femoral acetabular impingement, who knows? It's going to be very hard. I mean, we have to do some really dramatic somersaults to figure that one out. It would be very hard to suss out exactly what the long-term are related to the lengthening versus other things that happen to you during life.
It's so interesting you bring that up because, you know, I had a discrepancy in my tibia, and I do have some knee, I think bone spurs in my knee, and I had it lengthened, obviously. But was it because of my discrepancy doing long jump track and field for years on that joint? Lots of wear and tear, right? Or was it from the lengthening? We won't know unless we did a huge sample size of patients just like me. So that's really
very challenging.
Yeah. Okay. Your patient saying, I saw on Discord the screw that you were talking about, that proximal screw from earlier. It actually completely came out of the skin of a patient. Do all surgeons use a fully threaded screw now, since it's
I think I'm the one. I don't know what other surgeons do. That's why I mentioned it. I thought it could be helpful. I feel like that's something I do now because I've had 2 patients where it backed out. So I don't know, 50% is quite. Maybe Michael has more. I don't know, but one of the patients is coming to see me next week for me to pull it out because it's really bothering his skin. Like it is anxiety provoking. I don't like seeing the skin. Like I don't want an infection from the fact that that screw is so like pushing on the skin that we might get like a opening of the skin or skin necrosis. Like I'm not comfortable with that. One of the patients pushed it back in. I try to push it back in every time I see them. Then I pushed it back in and it stayed in because of the tension from the lengthening. And so that was great. And the other guy, I'm going to pull it out. So, and then now I don't see it anymore because now I always, the left medial, I always use a fully threaded screw.
So that doesn't happen as much.
No, it doesn't happen anymore.
Doesn't happen. Very cool.
Yeah.
Noah's saying, hi, Dr. G. Dr. Sinatz did a great job. I appreciate you recommending him to me last year. Oh, very cool. I'm wearing a made splint right now because he's doing his tibias right now. Yeah, just so you know, Master Distractor is one of Dr. G's amazing patients. He has a YouTube channel. I'll post it below. You can see all the stuff that he's been doing. He's been following her protocol. I'll post his YouTube channel below later, so you can check that out. Okay, so this one here from Do, he's saying, how safe is it to undergo another surgery, specifically jaw surgery, while recovering from limb lengthening? Is there a general guideline for how long patients should wait before doing so?
Yeah, so I'm not a fan of patients getting other stuff done when I have an active metabolic process in the bone, because you have an implant in your bone. Jaw surgery is where you have all the bad bugs. And so if that bug gets into your bloodstream and it's going to go to the active metabolic area, which means your bone is trying to make new bone and it's turning over bone and it's doing all this highly vascular stuff. If that bug wants, it's going to seed your regenerate site, and then it's going to seed the nail, and then you're going to have an osteomyelitis.
Oh, wow.
So I tell the patients, get a dental cleaning before we start, because for 6 months, it's a no-go. We're not doing dental cleanings. I like to be very cautious with that. Definitely, you know, I have a twin sister who's a plastic surgeon. A lot of my patients are like, well, while I'm here, could I do this? Or could I do this? Or could I do whatever? And I'm like, nope, you do it before, and then I do your surgery. You need a month between. You're not allowed to do that stuff while we're recovering, because I don't want any skin cut to potentially create a problem for infection.
Interesting. And like, how long after does the bone have to be fully ossified or consolidated afterwards?
I like it to be fully healed.
Okay.
I personally prefer taking out your nails before you do anything that's major, like jaw surgery, implants, like all that stuff that has to do specifically with mouth surgery. I'm not a fan of, because there's a lot of bugs in the mouth. And even if you take prophylactic antibiotics and all this other stuff, it's just not worth the risk. Like infection is one of those things. So personally, I prefer to take your nails out before you do anything. But if you have to have something done, I'd like the bone to be fully consolidated and slightly remodeled even, because the remodeling process is still a highly vascular process. So
interesting. So like not even during the consolidation, deeper, further out.
You know, because the consolidation, the bone is healed, but then you don't see the cortices yet, right? So there's a remodeling process that happens when it corticates. And so there is an active metabolic process still going on.
Oh my gosh, it can get into your bloodstream. Yeah. Okay, so Aiden Wahid is asking, if the PMAX is released and it's commercially successful, will the current Precice 2.2 be taken away?
No, I don't think so.
Okay.
So I think for medical need, first of all, I mean, I think that the company will, if they get the PMAX out, will charge more, even more than they're charging now, which is astronomical. So they'll charge more for the PMAX. And so that'll be still like a cheaper option. But also, when you only have to do one leg, if you don't absolutely need to weight bear, the PMAX is tried, tested, and true. We have like 20 years of data on this nail. Like this nail's not going anywhere, in my opinion.
Okay. Yeah, it's kind of like you have the newest iPhone, but you can still get the old generation.
Yeah, tried, tested, and true. For medical need cases, I think it's still a great solution. For sure, for aesthetic lengthenings, having a foot weight bearing nail is going to be the future. But yeah.
Very cool. So Dude's back with another more clinic-specific question. He says, your surgeries are in Montreal, but your physio teams are in Toronto, or also in Toronto. What would you recommend for someone who's in Oshawa, about an hour from Toronto? Should we stay in Montreal?
I have a big team in Toronto. Sometimes they have physios that can go like Hamilton. I'd have to check about Oshawa. So I have a team that we train there. I get so many patients from Toronto that it was worthwhile for me to have a physio team on site there. And then, so basically when patients come to have their surgery in Montreal, they stay with us for 1 month. We start the lengthening, we make sure everything's going well, and then they go back for the next 2 months. And we do virtual follow-ups. And typically they don't, if everything goes well, they don't come back until we do nail removal. So we just have to check potentially. So it has to be this group that I've trained. I don't like if patients want to go, they're like 2 hours outside of Toronto and they want, that's not going to work for me, because any physio that doesn't have experience with this is not going to be doing the right things. They just, it's not a bread and butter kind of thing. So it really has to be my team with Claudia at Get Right Physio. So if we have somebody, because we have a team there, so we have people that are from different parts of Toronto and outside of Toronto. So if she has someone that can come to Oshawa, then it's a go. And if it's not, you need to stay in Montreal for the 3 months.
Yeah, and I'm guessing it's an hour away. So would they come to them, or would they have to go?
Yeah, it's always home physio. So that's
wow.
the different physios live in and around the Toronto area, and so it's home physio. It's really like we do 5 days a week, so it would be very challenging for people to come to the clinic every day. So we do home physio. Yeah.
Wow, that's huge right there. Like having a concierge physical therapist at your door.
Yeah, but that's the best way. I mean, you really, that's, yeah, for sure.
I agree. Open the door, you're ready to go. All right. So Vitron's asking, if a person lengthens from 5'4" to 5'9", and their arm length is like 5'6", do you then recommend arm lengthening, or do you know prior to surgery or during lengthening that your arms are going to look like T-Rex arms?
Yes. So you look at arm proportions at the first visit. I think all of us do this. We look at how long the arms are, where they look, where they're ending at the level of the thigh. If you're starting off mid-thigh, you're good. Most people can get a 8 centimeter lengthening in the femurs and they don't look like T-Rex. If you're starting with your arms at pocket height, that's a problem. So then I would recommend a tibial lengthening, because when you do a tibial lengthening, you don't have that proportional aesthetic change. Just like when a woman wears a high heel, nobody says, oh, she looks like disproportionate. So that is, and it doesn't happen often. Most people have between 1, 2, or even 3 inches longer arms than they have legs. And so some people, it's like they're apes. Like you're just like, you were made for femoral lengthening. Like it's amazing. And they're really lucky, because then they look, they're mid-thigh when they're done.
Right.
That's a really nice, but generally speaking, we look at that, and we also look at the proportion between femur and tibias. You don't really want to like exaggerate your femoral lengthening if you have really short tibias to begin with. So those are the proportions that we look at to make sure. I haven't had to do an arm lengthening on anybody that was into some kind of dwarfism.
Really?
For cosmetic.
Wow, that's huge.
Not yet. Yeah, not yet.
Okay. Just because, because I think that you really do that assessment ahead of time, and I think
and they should be aware, because if they're going to have to do that, they need to know. I mean, that's a massive undertaking, right? Yeah,
proportions is a huge worry they have. P's asking, how long after femur surgery of, let's say, 6 to 7 centimeters before you can go back to work where you have to walk a little bit? No heavy work, nothing manual labor.
If you can do it on crutches or a walker, you can go back to work. We have some patients that are back at work at the office. They'll use their crutches or a walker, sit at the chair. I recommend that you see the lengthening as a part-time job. Yeah. So working a full-time job is an absolute no-go, because you need time to do the physical therapy, time to do your own stretches, time to use the machine to do the lengthening. You don't want to overdo it also, because your body needs time to recover and rest and eat well and fuel everything. So, but if you want to go into the office to do a couple hours, I had a lady do her dentistry work twice a week for 4 hours. Like there is a way to make it happen. And so I'd say you're probably forget the first month. That's out the window, because you're like, for the first 3 weeks, you don't feel like you're back to yourself. And then after that, I think if you have a couple hours of work to do and you can get there safely and get home safely, that's okay.
Absolutely. Yeah. It's just kind of transferring yourself properly.
Yeah.
Make sure you don't get knocked down by a crazy crowd.
Yeah. So like if it's super icy out, probably not the best idea. If you can work, the working from home is the best thing that can ever happen.
Absolutely.
Patients who work from home do great, because they're occupied all day. They have things to do. They're not bored. They're not sitting there, having their psychology like driving them nuts about So, because it's really, that's the most challenging part for patients is like, if you're an active person, you exercise every day, you can't exercise anymore the same way. I have some patients really motivated, get themselves a trainer, do their upper body work anyways, but it's a challenge. You feel like you're handicapped, right? So that part really drains patients. And I tell them this ahead of time, but until you live it and you feel it, you don't understand what it's like to be a handicapped person in this world. And so once you do this surgery, you have to use crutches, you have to use a walker, obstacles that you didn't even notice were there before. Now you see, because now, so that's the hardest part. It's the process. You know, like I said, I have this twin sister who's a plastic surgeon. If you're a woman and you get a breast augmentation, boom, you're done with surgery. They're there. Like, you're like, wow, this is amazing. That when you have limb lengthening surgery, we break your legs. We haven't changed your height, and you're just suffering. You're just like, there's nothing to see for the first little while, like, you know. Yeah. So it takes time. It's a process. So that's the part where it's like delayed gratification. You have to be really prepared and patient for that.
Absolutely, it's a 6 months of suffering, you know, but for a lifetime of happiness if you go through it.
Yeah,
you know?
I mean, I think most people, when they're on the other end, they think it's worth it.
Absolutely,
but when you're in it, it can be quite challenging.
For sure. All right, so we have about 10 minutes left. So if you have questions for Dr. G, the clinic at CLL Center, you can ask her now in the chat. Also, her link is below. So if you want to kind of visit the page and check it out and what she has to offer, you can do that. Link is in the description. But yeah, this is your chance to ask Dr. Marie Grdelovich your questions. So put them in the chat. I'm going through right now. All right, so this one, so it's about recreational hockey. How might longer femurs affect skating performance or lower body coordination long term if you do femur?
That's an interesting question. I have a patient that I lengthened, because this is a Canadian question. I have a patient that I lengthened as a hockey coach.
Oh,
really like high level hockey coach. And I wish he would have sent me the video of this, because he was not supposed to get on the ice with a walker.
Wow.
Yeah. So he got on the ice skating with a walker. I mean, I was going to kill the guy. This is what I mean about like complications and patients not listening. He's like, okay, you can partial weight bear. Oh, but I can skate with a walker. I mean, so I wish he would have sent me a video. That would have been priceless. So I mean, the guy's so happy with his lengthening. I don't think there is, you know, like, I think the one thing that people talk about is the back squat, because your center of gravity changes, but I don't know how a longer femur would affect your skating performance. I mean, the goal of this is not to increase your performance,
right?
But it's to get you back to where you were before. And I think for him anyways, he's way back to where he was before, and he's so happy with his height. But I never really asked him the question if it changed anything about the skating. I could.
Yeah. I've heard from some patients, like, you're right, like they've been skiing, skating, a lot of those things, they kind of find that they adapt really well, you know.
Maybe there's a difference in your center of gravity. Like, obviously there must be a difference, but I think your brain eventually just takes over
and picks up with it. For sure. So Mirini is asking, I probably didn't pronounce it right, but can lengthening cause temporary lordosis?
Yes, definitely. So if you get tight in your hip flexors, you can get that pelvic tilt happening, and then you can cause this lordosis. You have to, what we tell our patients when that starts to happen is that they have to be like the babies, tummy time. You know, when the babies have to learn to like use their neck and put their head up, we call it tummy time. Same thing. Patients have to spend time on their tummy, lying down on the floor on their tummy, watching TV, just getting that pelvis to stretch out. It's really very helpful, but it can happen. Usually it's temporary. That's the same reason why patients will come in at the end of lengthening and be like, I don't understand why I don't have all my length. The height is not because your pelvic tilt, your knees flex, all of this, until everything sort of flexes back out and you get that flexibility back, you're not going to get that final height measurement, and it's because of this, the lordosis, the knee flexion, all those things.
Got it. And how long after, let's say, you know, they're done lengthening, do you see a lot of that stiffness, those adhesions like resolve? Is it like,
so that first month when you're done, that first month of consolidation, you should be seeing like leaps and bounds of improvements, because the entire time you're doing your physio, you're fighting the lengthening.
Yeah.
And then when you're done lengthening, now if you continue to do the same intensity, you're going to get back your flexibility. So that first month is magic. A lot of patients will be, and so most of my patients by the 6-month mark are back to their normal flexibility if they've done their exercises. Yeah.
That's huge. Yeah. So, okay. Cause it's not, there's no more resistance from the length.
No. So if it took you 3 months to do that, and then you take another 3 months to stretch back out. But the problem is once you got your length, some people just ring the bell and like, I'm done. And then they don't continue doing their exercises. And so then that's where that, that's
interesting. Very, very cool. All right, guys. So we have about 10 minutes left, about like 5 or 10 minutes, and we're done.
Dr. Conway. I mean, I'm literally here trying to like
I know. Hold
hold down the fort so Dr. Conway makes it here, but I, knowing Dr. Conway, it's not going to happen. Victor.
No, not this time. We'll have to get on another time, but that's okay.
It'd be nice.
They love you. You're awesome. They're saying we love you. Okay. Okay. So this one, what does Dr. G think about the Fitbone for cosmetic limb lengthening? Will it do the job?
I think it will. I'm holding out to have the troch entry one. I'd like to be able to offer that to patients. I think from a price perspective, it's going to be easier for some people. And I want to be able to give them something instead of them getting, cheap surgery that's badly done somewhere else or a lengthening over a nail. Mm-hmm. I think Dr. Burkholz probably has the most experience, and I would probably chat with him before starting to do, because I use the Fitbone in my medical practice at the hospital, but I haven't done a cosmetic patient with Fitbone yet. We almost did one because we had a shortage for tibias. I'm very comfortable with the Fitbone nail in terms of the techniques and putting it in. I'm using a transport lengthening nail next week on a guy. Like that part, I'm happy with. I'm really excited about the troch entry nail. I think that's going to be a game changer for them. It's really designed for cosmetic. Mm-hmm. I think I spoke to their engineers in Italy about the weight bearing. I think that we're going to be able to push the envelope with the weight bearing on this nail. I think we'll start very, like Dr. Burkholz said, very cautiously, but I think we're going to quickly see that it's going to be a much stronger nail in terms of weight bearing. And so, the one thing right now is that it has this one screw at the distal end for locking. I'm not a fan of that. And so I'm basically waiting for this troch entry nail. It's going to have 2 locking screws at the top and at the bottom. Mm-hmm. It's designed to be able to be done for cosmetic. So because of that, I think it's going to be successful. I know Dr. Burkholz is going to be able to do the trial alpha run. And so I'll be very interested to hear from him, his feedback. Mm-hmm. But I think that it's definitely going to be a good nail. It's going to be a good competition for the Precice. It's time that there was some. And so I think it's going to do a good job. Yeah.
That's interesting. That battle of nails has started. I like it.
Yeah, well, it has to happen. I mean, we need
something else out there. Speaking of Fitbone, I want to continue the conversation about Fitbone. He's saying, Ben Mendoza is saying, I hear the Fitbone can go over the 8 centimeter mark on the upper legs and over 5 on the lower legs. Do you know the distraction length, the stroke of the nail?
It's still 8 centimeters. I don't think that's true. Yeah, it's still 8 as far as I know. And the troch entry nail that they're designing is only 8 as well. So
okay.
5 for sure. 5, the tibia goes more than 5. The tibia goes to 8 also. I mean, I don't recommend going to 8, but I think the nail itself goes to 8. Yeah.
Got it. And then his other question about the Fitbone is if it does come out, what will the price be? Do you know?
I mean, I think the only way they're going to be competitive is that they're going to come in at a lower price range than the Precice.
Yeah, I agree.
That's going to be they're into the market, and so I think you're looking at least $10,000 bilaterally for from a Canadian, maybe $5,000 a nail, maybe a little more. So wow. I think the price is going to for sure it's going to be lower, and we're going to obviously for me to use it, I'm going to put a lot of pressure on the company to bring the price down. Because that's going to be the main reason to switch to that nail for patients that can't afford the other nail. So I hope it's going to be even cheaper than that. But I foresee at least $10,000 worth of savings.
That's huge. That's huge. On the nail discussion here, we have John back with another one. Is cobalt-chrome with stainless steel a safe and widely used implant material for nails, or is titanium more biologically safe?
So the Fitbone is stainless. It's just that their lengthening mechanism is different, and so they don't have this issue with the rust. I think it just depends on the lengthening mechanism. The stainless steel nail that was the stride nail had a rust problem because the 2 interfaces, for whatever reason, couldn't figure it out to not have this problem with the rust, the corrosion. Cobalt-chrome is used in a lot of different orthopedic implants and is very safe as well. Titanium, it's not that it's biologically safe. One of the advantages of the titanium is that it's load sharing. Stainless steel is load bearing. Titanium is load sharing, which means that it functions with the body. It has that flex in it, which most trauma nails are made out of titanium because of that. We want a little bit of sharing to help load the bone so the bone heals. So it just depends what you're trying to do. But there are other nails that are starting to be talked about that potentially even Globus might be coming out with very shortly. That might be a full weight bearing nail. And so with a different technology than the magnet.
Wow.
So we'll see. Yeah.
Future of the nails. We'll see what happens. So Master Distraction saying, to do the accordion with the Fitbone, does the patient have to come into the office every day to use the retraction control?
Yeah, I mean, potentially not if we can get the reps to figure it out. That's the one like Dr. Burkholz is right, it does go backwards, but it's annoying to do. So something that there's probably the reps would have to come to your house every day. We wouldn't make you come to us, but we probably make the reps do the work if you had to do the accordion technique. Yeah.
Got it. All right.
But it's not something you can do yourself. You have to like play with the controller. And so, yeah.
It's a little bit more finicky.
It's a little bit annoying, but it's doable, which is important because if you need to do an accordion technique, I want to have that option with the Fitbone.
Right. Because you could heal the bone better. All right, so we'll take about 2 more questions and we'll let Dr. G do her outro. Unfortunately, Dr. Conway couldn't make it. We'll get her on hopefully in the next one. So, so Anand's back with another one. He's saying, how would a femoral patient know what, that the nail has bent? Can the patient feel it or can it only be seen in x-rays?
Very doubtful that the patient can feel it. Usually not, unless it's a massive bend, in which case we're looking at a nail exchange, which doesn't happen often. Generally, that's why we see you every 2 weeks. If I start to see a little bend going on, then I'm going to be like, you're putting too much weight. Let's review this again. Let's go through everything again. Make sure that you understand what you're allowed and not allowed to do, especially when you're fully lengthened out and if there's not a lot of bone. If you have good bone growth, and this is something that, you know, some patients just don't have the same bone growth. It's unfortunate. It's like one of those things, like maybe 1 in 10 patients doesn't make great bone. It's the part of their biology. And it's one of those challenges that becomes like, it just takes longer and it's very, very frustrating for the patient and for the surgeon. But those are the patients that are at the highest risk for the bending and patients who are like just doing too much generally. Yeah. So, so we will see it on the x-ray and then we will make you aware. And then, you know, if you're bending, every x-ray is bending a little bit more, you're clearly not following the instructions. So, because that shouldn't be happening. Now, there's a caveat to that. If it's happening and you're like swearing on your life that you're not, then maybe it's a tissue tension problem because there are massive forces going across. You know, if you have a very tight adductor, it could be bending the nail into varus. Wow. So then sometimes we back up, give a chance to get the flexibility back, and then we go back forward again.
Interesting. And how long between like that time of you trying to like get that muscle loose would you risk pre-consolidation? Is there like a time?
No. I mean, pre-consolidation to me is not a real thing.
Real risk.
Not how many patients have pre-consolidations at all. I think it's more of a you didn't do the osteotomy. You didn't complete the osteotomy at the time of the surgery. Or it's like a pediatric patient who, like, I don't know, if you haven't lengthened the right way with a fixator, or like, but with a nail, or if the nail doesn't lengthen for, I don't know, 4 weeks, then you're in trouble. But otherwise, you shouldn't have a pre-consolidation. Even if you back it up and you bring it back forward, you have at least 2 weeks that you could do that with.
Okay, at least 2 weeks. That's plenty of time, yeah. All right, guys, we're going to take, let me see. Okay, you guys have any good questions for Dr. G? Okay, so here we go. So she's back with another one. Once the bone is consolidated, does the nail matter and the hip rotation walking matter?
So then once the bone is healed, the nail is doing nothing, zero. Okay. So that's like but I personally like to see the remodeling before I take the nail out. I like to see the cortical consolidation before I take the nail out. So it takes about a year from surgery. But no, the nail is not doing anything. The one thing that patients do complain about sometimes is the screws at the top where the troch is. They might still feel those screws a little bit. So they're happy to get their nail out, but otherwise you could do whatever you want. Once you're done healing, you're done. You could do whatever you want.
Okay, very cool. That's awesome. All right, well, last 2 questions. These are quick questions. So P saying, how high is the risk of complication in the femur lengthening, and is misalignment often the mistake of a surgeon?
Yeah. So that's a good question. It's not that high. It really isn't for femoral lengthening. I'd say like there's more complications in the tibias typically. Femoral lengthening goes fairly smoothly most of the time. Now there's some things like, you know, we have no control over it. I'm going to knock on wood again. I haven't had an infection yet, but it's going to happen. It's like a 1 in 1,000 thing. Eventually there's going to be that thing. But we have had in the past patients get a blood clot. And so now we're screening patients with an ultrasound once a month, which I think is nice because then I'm just really relaxed about it and I don't have to worry about it. And they're obviously on anticoagulation, but despite that, we had a patient get a blood clot in the leg. So I don't want to, that's the kind of thing I don't like risking because that could be like medically dangerous and I don't want to put a patient's life at risk. So we're screening people. Misalignment. So I think I'm the only one who puts an X-fix on when I do this. And I use the gyroscope for rotation. So I'll put the pin in the distal femur and a pin in the proximal femur, and I will check that the alignment is exactly the same as when I started. Break the bone, check it again, lock it with an X-fix, like a bar, pin to bar, and then finish doing the nailing. And that makes locking very easy. What can happen, you're putting in a nail, you want to get the perfect circles, you move the leg, and then you can change the rotation on a patient. rotation. So that can be quite easy to do, and that's definitely surgeon error.
Yeah.
So well, or it's a technical error.
Technical error, yeah.
Yeah.
So it can happen both ways in that
Yeah.
sense.
So I really like to use an X-Fix when I do this to make sure. Now, a lot of people use a rotational marker or something else to make sure that they don't do that, but I'm the only one I think who's using an X-Fix.
Interesting. Wow, that's crazy. Okay, so always be careful. That's his little ABC. That's right.
Yes.
All right, this was the last question that we picked on for here is when can patients use treadmills?
Yeah, so treadmills are a tricky one because you actually put more force in your legs when you walk on a treadmill than you do when you're just walking on the ground. Your reactive forces through your body that go through a treadmill, you like I don't know if you've noticed, like people who run on a treadmill, it's like bang, 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 bang. Like there's a lot of impact. And so for me, the treadmill is really like when you're done healing because it's not a great one. It's good for like the vibration effect and getting that bone to buff up, but you have to have 4 cortices for me before you're using a treadmill.
Got it. So that's like one of the last things when they're fully cleared.
Yeah, unless you're using those fancy treadmills that people have now.
Yeah,
The
like
anti-gravity.
soft.
Yeah, the anti-gravity stuff. But
Anti-gravity, yeah, that's what it is. All right. He just he just threw this one in here. You mentioned a new nail from Globus having a different lengthening method. Any idea what that will be?
Yeah, it's gonna be. I always get this wrong because it's like a word I can never remember. Yeah, I won't remember it now for sure. It's like an internal coil mechanism that they're going to. It's either like heat or I can't remember exactly. There's something that's gonna, and then it's going to lengthen. It can't go backwards. So it's like, so it's going to be one of these things that it can go this way as it like expands basically, but it can't go backwards. But it will be a full weight bearing nail that they're working on, and I think it's like the PMAX. They're still working on it, but is it something in the woodworks?
Interesting.
Night call. It's not. I can never remember the word.
Oh, knitting nail.
Yeah.
Yeah, I've heard of that name being tossed around.
Yeah.
Years now.
Yeah, exactly. So that one I think is coming to fruition finally. I don't know if it's going to be marketed for aesthetic lengthenings or it's more trauma nail. I'm not sure, but
interesting. Okay, very cool. Well, Dr. G, the mic is all yours. We really appreciate you coming on. So what can you tell, any last words to your future patients?
Yeah. So like I said, I mean, I'm excited about my sabbatical year from the hospital. I think, my patients are always worried that I'm like torn in 12 different directions, which they're not wrong about, but I'm always available. That's, but I'm excited to work a little less, which, the hospital life is a bit intense. It's like today I was on call, wasn't sure I was going to make it. And so I'm excited to focus on the Canadian Limb Lengthening Center. We have a lot of exciting things coming up. We want to open a foundation. We want to open a course. We're going to start a fellowship. Like this year, I'm going to get a few partners. Like we're really going to expand the concept. It's been a one-woman show for a little bit too long now. And so that's I'm really excited about being able to do that. And I'll be doing a bit more traveling for some, I'm going to South Africa in September, so I get to see Frank, and that'll be fun. And so it'll be an exciting year, and I'm excited to focus on what I love doing. It's not just aesthetic lengthenings, it's deformity correction, limb lengthening for all my patients in Canada and internationally. But it will give me a chance to focus also a bit more on the aesthetic stuff. And I'm happy to take feedback from patients on what challenges we still have when they're coming to Canada, because we'd like to try to make the process easier for them. Like right now, getting a visa is not that hard, which is great, which is one of the reasons we're getting a lot of patients. I think in the US is struggling a little bit. But other things like accommodations, what else we can do. I always take feedback. Like Master Distractor gives me tons of feedback. Most of my patients give me feedback and I'm very open to it. Just don't be rude about it. And then we try to take that and make things better all the time. So there you go.
That is exciting. Super happy for you. Like I said, one of the fan favorite surgeons that we have on the show. So thank you so much for coming on today, spending time with the patients, answering the patients' questions, because all the other surgeons had to leave, but you stayed here to the very end. Held down the fort for Dr. Conway. Unfortunately, she couldn't make it, but next time she will. So everybody, that is Dr. Marie Gadailovich from the Canadian Limb Lengthening Center in Montreal, Canada. You can check out her link below. It shows the link to her website. Feel free to visit, check out all their service offerings. So Dr. G, thanks so much for joining us tonight.
Thank you again, Victor. Appreciate your time.
All right,
take care, guys.
All right, guys. Have a great night. Take care. Bye.